Hey Jake, can you text me the meeting number so I can join on my laptop? So I'm not trying to do this on my phone. How many people are supposed to be here tonight? Do we know?
I'm not sure off the top of my head. Supposed to be. I don't know.
All right, can everybody hear me?
Yep.
You're good.
Yeah,
Perfect. I'm
I
gonna
can
go
hear
ahead
you.
and get started. Obviously this lecture will be accessible after the case, so I want to get started sooner rather than later. Um, so I got assigned this last minute by Jake. He's got some stuff going on. Um, Correct me if I'm wrong. We're supposed to be covering chapters 29, 30, 31, and 32.
Yes, that is correct.
Okay, perfect. We're going to start with bleeding and shock. I typically like to lead off with this lecture simply because um, identifying shock is pretty much the bread and butter of what EMS professionals do. Um, if you don't understand what shock looks like or what shock does, then we don't know what to do once we identify what the problem is. So, um, brief view of the circulatory system, shock, and then obviously bleeding. If you've done this for a while, you know what arterial versus venous bleeding is. Quick overview of what the circulatory system is. Everybody knows that the heart and the lungs are more or less connected at the hip. Without one, the other doesn't survive, and vice versa. So, not just the cardiac system or the pulmonary system. That's the reason it's called the cardiopulmonary system. Is they rely very heavily on each other. Um, all gas exchange happens in the lungs, and then obviously the pump is responsible for circulating both oxygenated and deoxygenated blood. Also other things in the blood, but those are the biggest things is oxygenated and deoxygenated blood. Um, Left side of the heart and all your arteries minus the pulmonary artery um, circulate oxygen rich blood. It's typically somewhere in the 97% saturated rate is average. And then the venous system or the veins minus the, excuse me. Oh, no, that's it. Sorry. They minus the um, pulmonary vein. Sorry. Jeez. Losing my mind. The pulmonary vein, um, returns blood from oxygenated blood from the lungs to the heart to circulate to the body, where the pulmonary arteries take oxygenated blood away from deoxygenated blood away from the heart to the lungs for reoxygenation gas exchange. um, the biggest portion of the heart, biggest job of the heart is to pump the blood. Um, Obviously, without the pump, no circulatory system works. Without pressure, there is, you know, and if you're on a fire truck without your pump, you ain't pumping water because gravity ain't nothing. um, with that pumped blood supplies oxygen and nutrients to the body's cells. When we talk about an adequate rate and an adequate rhythm, I also like to talk about an adequate contractility. I don't think that that's covered enough early on in this career. A pump can be you be running at a good rate and a good rhythm, but if it's not squeezing hard enough, it's not pushing any fluids. Those are your heart failure patients. Covered this a little bit. Arteries carry oxygenated blood away from the heart. That's why the pulmonary artery is called what it is, even though it, excuse me, hold up. Did they change this? My apologies. Had to double check myself. They did change it. The pulmonary arteries carry deoxygenated blood away from the left side of the right side of the heart to the lungs, and then the pulmonary veins carry oxygenated blood back to the left atrium to be circulated through the body. Arteries uniquely are similar but different than veins. Arteries have muscular walls that enable dilation and constriction more so than veins do. Capillaries is where all life exchange happens. They're microscopic blood vessels. Anytime that you get an abrasion or a small burn, that seep, that's a rupture of a capillary. That's where oxygen and nutrients, as well as the exchange for carbon dioxide, happens away from cells. So those are interlaced in your muscles and all of your organs. Veins carry oxygen depleted, blood-rich carbon dioxide back to the heart. If you ever worked in any kind of plumbing, they contain one-way valves. I'm sure if you've ever been in the back of an ambulance, you heard a medic complain about hitting a valve. They're one-way check valves. They only allow blood to go through them, and then they close, preventing backflow. That actually what creates your preload in the circulatory system to allow blood to return to the heart. The main components of the function of blood is the transportation of gases, primarily oxygen and carbon dioxide. Nutrition, such as glucose. They also aid in getting rid of a lot of your excess electrolytes and sugar, primarily potassium, magnesium, and calcium. They also serve as a kind of a buffer during trauma, and then without water, you wouldn't have sodium, so you wouldn't have the regulation in your endocrine system. Perfusion is exactly what people preach is it's the adequate circulation. It's actually the adequate delivery of blood throughout the body. I wouldn't say circulation, I'd say delivery. Hypoperfusion is inadequate perfusion of any portion of the body's tissues and or organs. Hypoperfusion is shock. That's the easiest way to remember that. Going into shock. Shock is inadequate tissue perfusion. If hypoperfusion persists, cells and organs die at a very, very rapid rate. That's why we talk about the golden hour or we used to talk about the golden hour as far as treatment goes for strokes and STEMIs. I don't remember the exact number, but it's millions of brain cells per second that a person loses during a stroke. Pathophysiology of shock. There's 4 types of shock that they're identifying right now: volume problems, pump problems, blood vessel tone problems, and obstruction. So we've got hypovolemic shock, cardiogenic shock, and then distributive shock, and then obstructive shock, as sometimes how those are referenced from top to bottom. Hypovolemia, blood is lost. Absolute hypovolemia, plasma is removed from the circulatory system. Relative hypovolemia, you can sometimes see those relative hypovolemic patients after a plasma donation. Um, moving forward, in the hypovolemia, if there's not enough blood in the blood vessels, pressure fails. I talked about it just a little bit ago. Preload affects afterload. Without an appropriate quantity of fluid on the intake side of the pump, i.e., the right side of the heart, there is not enough pressure to be pushed through the rest of the circulatory system to create good pressure on the left side or the arterial side of the circulatory system, and that limits blood flow. Both absolute and relative hypovolemia are called hypovolemic shock. Hemorrhagic shock is a loss of blood. So hypovolemia and hemorrhagic shock are kind of different. You can have a hypovolemic state and still have an appropriate quantity of red blood cells. Hemorrhagic shock is strictly just the loss of whole blood. Pump problems. I touched on this just a second ago. Failure of the heart. Failure of the heart to pump blood. It's usually called cardiogenic shock. And that's usually in a direct relation to the heart's inability to adequately pump or circulate blood. Blood vessel tone. These are going to be your neurogenic, your septic, your anaphylactic shocks. These are what we call vasodilatory states. Whatever causes the blood vessel to dilate is kind of what points it in the type of shock that it is. If it's a antigen causing an anaphylactic reaction, it's anaphylactic shock. Neurogenic shock tends to happen with like brainstem injuries or cervical spine or thoracic spine injuries, because below the injury, they lose the ability to control vascular tone. During septic shock, lactic acid causes a gross vasodilatory state that their body isn't able to maintain a good blood pressure. Obstructive shock is caused by big embolisms, saddle pulmonary embolisms, cardiac tamponade or tension pneumothorax. I like to teach people obstructive shock is pressure shock. Because you think about it, you're putting outwardly pressure on the heart or the lungs, or completely obstructing the blood flow, and that the most common place for that is the saddle junction of the pulmonary arteries. During fight or flight, I'm sure you've touched on the sympathetic versus the parasympathetic nervous system. The baroreceptors in your blood vessels, as they start to dilate, can cause a stimulated release of epinephrine and norepinephrine. It causes your blood vessels to constrict, your skin to be pale, cool, and clammy, because your body is forcing all of the blood from your fingers and your toes to the core to that whole fight or flight. You become sweaty because perfusion is lacking in those distal capillaries. Kidneys produce less urine simply because, one, you've got a decrease in perfusion to them, and also epinephrine, the adrenal glands, slow down the loop of Henle, causing your body to hold on to fluids. It's not uncommon for somebody who's had a massive adrenaline dump to feel sick to their stomach and to throw up. The release of epinephrine and norepinephrine, or adrenaline and norepinephrine, increase your heart rate and your heart's contractility. Also, the norepinephrine affects vasodilation. It somewhat helps your body regulate vasodilation. Compensation. Compensation is when your body realizes that there's a problem, and it does something about it. Depending on what the cause is, how your body attempts to regulate or compensate for the problem. Regulation of volume, regulation of fluids, also cardiac response, vasoconstriction, All of those are all really dependent on the intruder or the cause of the need for compensation. Compensation kind of works across the board for everybody. It's typically going to be you'll have a increased respiratory rate, an increased heart rate, and a somewhat normal blood pressure. That's that's when your body's compensating. Kids is a side note, and I would take note of this is any pediatric patient that looks sick is sick until proven otherwise. Never rely on a drop in blood pressure to identify a pediatric patient is in some form of shock because they're compensating and they're small. And kids compensate 10 times better than adults do, and their blood pressure is the absolute last thing to go. Once you lose a pediatric patient's blood pressure who's in shock, they go from compensated to almost immediately into irreversible shock. Their only mechanism for compensating for shock is their heart rate. So if their heart rate is 40 points above normal, they're in shock until proven otherwise and treat them accordingly. Decompensation. Compensated shock requires more fuel. That's what we do. We add fuel, right? Fluids. If you're on an ALS ambulance, we add medications, uh, vasoconstrictors, or positive inotropes, positive chronotropes, etc. However, decompensation happens when the body runs out of fuel. Compensated shock becomes decompensated shock when you have a gross drop in blood pressure, a mental status change, and they go from being tachycardic to having a normal heart rate and a slow respiratory rate. And that's when you're right there on teetering on that edge into irreversible shock. Irreversible shock leads to what we used to teach was as MODS, or multi-organ dysfunction syndrome. This is big fancy words for the organs begin to die. And that happens fairly quickly. Minutes to hours. Your kidneys are kind of the toughest of the group because they can somewhat fix themselves. Once your heart and lungs start to go, it's game over. Patient assessment keynotes is identify the underlying problem, recognize whether they're in a form of compensation or not. Scene survey for mechanism of injury illness. Obviously, anybody who was riding a moped who got hit by a car has high mechanism of injury, high suspected need for further treatment than somebody who tripped and fell. But perform a good primary assessment and identify the underlying problem. With every patient, we're going to correct airway problems immediately. Breathing. Never allow a hypovolemic patient or a patient in a form of hypoperfusion to remain hypoxia because they're already struggling due to whatever it is hypovolemic. They're already dealing with a delivery problem. Let's not deal with a fuel problem as well. Treat the hypoxia with supplemental oxygen appropriately. Document skin color. Distal pulses is a good one. I like to check pedal pulses and radial pulses on every one of my patients who's pale and cool and clammy, because there's a number of things that could cause a pale, cool, and clammy where the outside work and they come inside and that's why they're pale, cool, and clammy. Or are they have very little signs of perfusion at the wrists and the top of the feet. Obviously, we're going to treat problems found in the primary assessment immediately. Biggest one is control arterial bleeds. Second to that is correct hypoxia. We're going to identify shock in trends in the vital signs. Obviously, if a patient says that my normal blood pressure is 100/60 and they're 100/60 and their skin looks pink, warm, and dry, they're probably telling you the truth. But if your patient's skin is pale, cool, diaphoretic, then their blood pressure is 80/60, Now we need to do something. Physical examination. I preach this, I harp on this on a regular basis. Touch your patients. Touch your patients. Touch your patients. Because physical assessment is going to help you identify things that you not necessarily wouldn't notice. Because a lot of times patients start to become pale, cool, and diaphoretic on their chest and their back long before their palms and their feet. And I don't know why. That and you're going to have a much larger area to see. If their entire chest and their entire back is diaphoretic and they've been sitting on the couch watching TV for the last 2 hours, it's concerning. History taking, mechanism of injury, and history of the present illness. History of the present illness. Well, primary example is your patient is 65-year-old female with a history of CHF, COPD, and emphysema, and they're breathing 42 times a minute and hypoxic. It's that the cause of the problem. And then find out what their chief complaint is. Not what dispatch told you their chief complaint, what chief complaint is. What caused them to call 911? So this illustration kind of covers what we just talked about. Stage 1 is pulse increases to maintain cardiac output. Cardiac output, stroke volume times cardiac output's what's used to calculate minute volume, which is how much blood circulates through your circulatory system in a minute. Once that starts, that's initiated by the release of adrenaline or epinephrine and norepinephrine that causes the blood vessels to constrict, causing pale, clammy skin. Respiratory rate increases. Blood is shown away from the GI organs, causing nausea, primarily the stomach and the large intestine. And we're going to monitor them for either a increase, a stabilization, or a decrease in blood pressure, which is going to determine whether or not they stay in shock, in compensated shock, decompensated shock, or irreversible shock. Obviously, treating shock, this just depends on what is causing it. What is causing this patient to be in shock? Best way to resolve hypoperfusion or shock is to stop whatever's causing it, i.e. anaphylaxis, treatment for the allergic reaction, epi, solumedrol, Benadryl, updrafts, etc. Stop the invader. Sometimes it means surgery. Sometimes it means that their spleen ruptured and they needed surgical intervention. We use our primary assessment to identify urgent interventions. I don't know if you remembered me preaching this during the medical portion of this, the ABCs. That is to find what is going to kill your patient now. Patient assessment, it also is to identify your treatment needs and what does your patient need? Does your patient need surgery now, or do they need a neurologist to figure out why they can't feel their legs? So the deadly triad of trauma, there's actually 4 pieces to this, but we're only teaching 3 right now. Acidosis, which is what lactic acid is produced by the body in anaerobic metabolism, which is either the lack of sugar or lack of oxygen. Typically in shock, it's a lack of oxygen because the cells have a sugar reserve. When they shunt the blood flow away, they suck the delivery of oxygen away. Hypothermia. Hypothermia actually directly leads into the third portion of this, coagulopathy. Coagulopathy is a big fancy word for the inability to create a blood clot. Coagulopathy is typically affected in 3 ways. The biggest one is loss of platelets. That's going to be in your trauma patients. Number 2, lack of white blood cells. Those are going to be in your immunocompromised patients. And 3 is hypothermia. Hypothermia actually almost without prejudice stops the production of fibrin, which fibrins are one of the most crucial portions of a blood clot. Treatment of the deadly triad. Obviously, we're going to get them to a hospital, right? We're not going to take them to an urgent care. And sooner rather than later. Prevent hypoxia. Excuse me. Prevent heat loss. Cover them with blankets. Turn your AC or turn your AC off and your heater on. I know it's going to be uncomfortable for you. It's 85 degrees outside. Mima's got a core body temperature of 92 degrees. We've got to fix that. Turn the heater up. Shock positioning. I think they're still teaching the Trendelenburg. Correct me if I'm wrong. I like to tell people to put the head of the cot at about 5 or 10 degrees and then raise the legs. That just kind of pushes blood to the core, helps force vital end organ perfusion, and then obviously consider advanced life support. Anybody who's in some form of shock probably needs some form of ALS intervention, so it would behoove you to wait. Rapid transport, 8 to 10 minute scene times is what I like to preach to people, unless, obviously you got multi patients and you're waiting for assistance. 8 to 10 minutes is doable. Manage specific underlying causes of shock. Obviously, it's bleed, stop the bleed. Manage airway and breathing to prevent hypoxia. OPAs, NPAs are not out of the realm of possibility for an EMT, and then utilizing BVM to assist ventilations if needed. Take steps to prevent heat loss. Like I said, place them, put them on a blanket, turn up your heater, put them under a blanket, turn up your heater. If you put the patient in a supine position, you can elevate their legs. It's kind of a 50-50. People still teach that, people still don't. I don't know if it's still a test question or not. The Trendelenburg position is, my understanding, controversial. And then request ALS intercept if necessary. Bleeding is pretty straightforward. We're all adults. We've all cut ourselves. We know what bleeding is. There's 3 different types of bleeding that I like to teach people about. We've got external arterial bleeding, internal vessel bleeding, and then internal arterial bleeding. Very similar in presentation. All 3 of those, because all of your blood vessels on the inside are much larger than the blood vessels on the outside. If you look at a diagram of what the internal jugular versus the external jugular vein, which is in your neck, is twice the size of the external jugular. And you've seen some of those people that have, neck veins that are the size of your pinky. You think you've got an injury to one of those blood vessels on the inside that you can't see how much blood they've lost. Flip the coin on an internal arterial bleed is probably worse. I touched on this. Arteries spurt and they pulse with each heartbeat. They do have a little bit of a brighter red color. In the heat of the moment, it's kind of hard to see until you get real close to them. Venous blood flow is more steady. It's got kind of a darker red color. And capillaries we touched on too. Capillary bleeding is the least of the concerning, unless there's other injuries. External bleeding happens when you have something that penetrates the skin and or musculature and destroys or damages underlying blood vessels. It's typically visible on the surface of the skin. Obviously, how much a person bleeds is going to be determined by the size of the wound, how deep it goes, and the individual's ability to develop a clot. All of your anticoagulated patients who take Eliquis or Plavix is a good one. Plavix, they don't clot worth a darn because Plavix is a really, really potent platelet aggregate. Arterial bleeding, bright red color. These are going to be the injuries that need tourniquets. Direct pressure is not going to control these injuries. The sooner you get a tourniquet on them, the sooner that you can start to help their body realize that the damage is done and they can start to self-regulate. Venous bleeding, those are going to be the wounds that are controllable with direct pressure bandages. Still going to lose a lot of blood, but they're not going to be nearly as bloody as an arterial bleed. Junctional hemorrhage. I don't know if anybody's ever heard that term before. We teach it a lot on my side of things. Junctional hemorrhage occurs where body parts attach. So armpits and shoulders, groin and neck. The biggest reason that those are of concern is, well, one, you can't put a tourniquet there, or you can. There's specific tourniquets for it, but hardly nobody carries them because they're bloody expensive. And two, those areas are where some of the largest arteries and veins that lead to your appendages sit, and they're relatively unprotected because they're coming out of the cage, is what I like to call it, everything between your chin and your pelvis, out to an appendage. So they're relatively unprotected. If you think about it, your aorta, your superior and inferior vena cava, those are relatively protected by your ribs, your heart, your lungs, and your spine because it's wet. It runs right down your back. Same down weak into the abdomen. You've got the cushion of the abdomen, the small and large intestine, and on the backside you've also got the spine. Once you get down to the femoral arteries, it's just muscle, and it's protected on one side by bone. So considerably less protected than the core of the body. Capillary bleeding, superficial wounds, slow oozing. Those are going to be your bumps, bruises, or bumps and abrasions. And I mean, for other than a lack of terms, are more or less irrelevant. I mean, make your patient comfortable and cover them up, but they're not what's going to kill your patient. um, the things that can cause accelerated blood loss, prescription medications. I covered a couple of those that inhibit or limit your body's natural ability to form clots. Also, hypothermia affects the body's ability to build clots. Hypothermia starts affecting the clotting cascade at 95 degrees core temperature. So if you think about it, you've got a resting core body temperature of about 98 degrees. So fall, break your hip, lay on your floor for 4 hours, and you've got a core body temperature of 95 degrees. Your body's ability to manage hemorrhage has already been affected. External hemorrhage, usually controlled by compressing the tissue around the room. That's what I was talking about, pressure dressings. I'm sure we'll cover a lot of those during the skills day. Precautions with external hemorrhage, obviously, try not to get anybody's blood on you as best as humanly possible. And then always wash your hands and arms and boots after each call. If it's possible, if you know you're going to a really bad trauma call, it looks ridiculous, but wearing one of those surgical gowns will save you a buttload of work later. So as you're walking up to your patient, identify really bad bleeding versus bad bleeding versus normal bleeding. Massive hemorrhage is what I call really bad. Those are going to be your patients that are probably either large venous or small to large artery damages. How does the severity of the bleeding affect your treatment? That's a question for somebody to answer.
Can you say that question one more time? It kind of bleeped out on me a little bit.
How does if there's a massive hemorrhage, how does that affect your priorities in treatment?
Obviously, the bleeding is a life threat, so you need to treat the bleeding before you do anything else.
Perfect. Stop the bleed, right? We covered it. I hammered on it during the medical assessment. We're going to go over it when we do the trauma one. If you're during, and that's why it's in the ABCs. If you're just walking up to your trauma patient, you identify an arterial bleed, stop what you're doing and fix it. So ideally, if you identify an arterial bleed, you should be able to identify any arterial bleed within 15 seconds of patient contact and control it. I'd control the bleed, open the airway, and help them breathe. That's the number one hallmarks of trauma patients. Stop the bleed, open the airway, help them breathe. Because most of your head trauma patients are not going to be protecting their own airway. They're going to need assistance breathing. And we covered hypoxia, hypothermia, and coagulopathy kills people in shock, right? So hypovolemic shock patients, stop the bleed, fix the airway, help them breathe. Controlling non-massing bleeding only after assessing and treating prior elements. When I'm talking about that, you treat all of your life-threatening injuries first. I don't care if they got a cut on their toe. If they've got a radial artery bleed, then we fix that, then we deal with their toe. Obviously, anybody who's tachycardic, who's got pale, cool, and diaphoretic skin is in compensated shock until proven otherwise. Um, Easiest modes of controlling external bleeding, direct pressure, hemostatic agents. I'm sure you've heard of quick clot. Surgeons will either love you or hate you for it. Most of them will hate you for it. Wound packing is just how it sounds. You take gauze and you pack it in the wound until the wound is full of gauze, and then you wrap it up. Unless it's the abdomen. We don't pack the abdomen. Tourniquet, its primary use is going to be extremities and base, obviously for shoulders down, hips down. And then there's specialized compression devices for junctional bleeding. There's some junctional tourniquets. Sam makes one, I believe. Stopping the bleed is essential from preventing decompensated and irreversible shock. If your patient requires some kind of intervention from you, then they're likely in some form of compensated shock already. Obviously, uncontrolled bleeding leads to death. Standard precautions are mandatory. I say if you don't wear glasses, some sort of face shield and gloves, but at a bare minimum, gloves. And then always, always, always wear gloves when you're cleaning up your apparatus and equipment afterwards, because that stuff gets everywhere you expect it not to be. We like to teach least invasive to most invasive. So obviously, if you've got what appears to be a venous bleed, try to control it with direct pressure first. Apply firm pressure to the wound with the palm of your hand. Hold pressure until the bleeding stops. Once the bleeding is controlled, bandage a dressing firmly in place to form a pressure dressing. So the idea behind it is you don't need something to absorb the blood coming out of it. You need to compress the tissue that's been traumatized to force it to start developing its own intrinsic clotting factors. So once the blood flow stops leaving the body in a rapid rate, all of those clotting factors will start to develop the clot. So once the bleeding stops, that's when you bandage it. And then we don't take them off once they're on. That's a doctor's prerogative. Wound packing, this is going to be primarily your junctional areas, armpits, shoulders, and groin. If you've ever seen a stop the bleed campaign or training, it's quite the thing to watch. Obviously, direct pressure should be augmented by wound packing if direct pressure doesn't work. Fill the void spaces with hemostatic gauze. What that means is whatever is not going to be in direct contact with whatever vessels are bleeding. So if you can find the blood vessels that are bleeding, you pack those and pack those around them. The hemostatic gauze goes in the tissue surrounding that because you don't want to burn or cauterize arteries or veins. Pressure dressing, several gauze pads. I like to teach people, depending on the size of the the size of the wound, that roll of Curlex that we carry, it's great. Cut it down to size, just slap it on top of the wound, and then wrap the rest of it around it. Um, you don't want to create enough blood pressure to stop circulation. That's what tourniquets are for. The idea is just enough pressure to stop the bleeding. Hemostatic agents, they're 50-50 whether or not people love them or hate them. The idea behind them is it interacts with the iron in the blood and it heats up and it actually burns the tissue cauterize the wound and stop the bleeding. Biggest benefit they have is in junctional hemorrhage because it's a more or less a Hail Mary, trying to stop those bleeds. Quick clot combat gauze is one of the more common hemostatic agents that you'll run into. I think we carried the 4x4s. We don't carry the rolls of it. Tourniquet. The idea behind the tourniquet, as we talked already, is it cuts off blood flow distal wherever you put it. And this is for any bleeding that is not controllable with direct pressure, venous or arterial. If you cannot control a venous bleed with direct pressure, tourniquet. Because we've got to make sure they maintain a large enough quantity of blood to make it to the receiving facility. If they want to let them sit there and bleed, they can do so. They have blood. Most tourniquets are pretty similar in application. The soft T wides, I think the biggest difference in all of them, but they're pretty straightforward, and most of them can be applied with one hand. Tighten them down as tight as you can get them with hand, and then utilize the windlass or the twist device to stop all blood flow distal to the tourniquet. The attach a notation to the patient alerting other providers the tourniquet has been applied. The easiest thing to that is just expose the appendage in which it's on. Don't leave your patient clothed. There for a while we were writing big T's on people's forehead in permanent marker to determine to signify that they had a tourniquet on their body, and that's, I guess, immoral. For me, it's like I said, expose the appendage, cut the clothes off. It's hard to miss that your patient has a tourniquet on when they're laying there, and the only thing that's covered is their nether region, and all of their appendages are exposed because those are the only places that your tourniquet should be. Junctional tourniquets. I'd say it's going to be hard for me to show you one of those, but I would research it. They're real similar to a regular tourniquet, and they have kind of an aspect of a blood pressure cuff to them. The idea is to put pressure on the axilla, the armpits, and the groin. So as you're treating your patient, you decide that direct pressure is probably the best course of action. How do you know it's working?
The bleeding stops.
The bleeding stops, right? Do we need to escalate? If we're in a situation where we've got venous bleeding, even though it's venous bleeding, it's a large vein that we've got damage to. Do we need to go to a tourniquet to make sure that they keep enough blood to live, right? We can cut off circulation to arms and legs for 6 or 8 hours, and there be little to no deficits. Elevation, obviously, creating a larger or increased pressure that the body has to push against to perfuse an extremity makes it harder for the blood to get there. That can actually help you a lot, especially on your forearms and from knees down. If you can elevate the patient in conjunction with direct pressure, great. Only time we don't want to do this is if we expect a spinal injury. There's an obvious deformity to that extremity, or there's an impaled object in that extremity. Splinting. Um, its purpose is to stabilize the sharp end of broken bones so we don't cause any more internal trauma that has already happened. Um, Cold packs actually do more than just relieve pain. They minimize swelling. Swelling is the number one cause of pain. It constricts blood vessels to that area, slowing the influx of blood, reducing the chance of compartment syndrome. Um, it's a good tool for that, in my humble opinion, that gets underutilized by everybody, including myself. Head injury, increase in cranial pressure. Um, so head injury can cause like bleeding from the eyes, the nose, and the mouth. Um, that's not a direct cause to a direct trauma to the ears or nose. Stopping bleeding from the eyes, nose, or mouth actually increases intracranial pressure and can cause worsening neurological outcomes. Um, if you note bleeding from the nose or the ears or the mouth, that is, it'll look like it has like an oil slick on the top of it. That's because it's mixed with cerebral spinal fluid. Don't try to stop that bleeding. Just utilize gauze to collect it. Um, Nosebleeds, everyone's probably dealt with one of these, but have the patient sit up, not back, sit straight up and lean forward. You want pressure to the cartilage portion of the nostrils and talk them through it. Don't let them lean back because every time they lean back, all that blood that's accumulated in their sinus cavity is going to go rushing right down the back of their throat, and they're going to want to throw up at you. um, if they get so bad that they become unresponsive, we put them in the recovery position and we suction their airway um, and assist ventilations afterwards. So, brief overview of patient care for bleeding patients. We start with direct pressure. We consider hemostatic agents to augment direct pressure. It's not a frontline treatment. The need for wound packing in our junctional hemorrhages. Consider the use of a junctional tourniquet if you have one. If not, then we wound pack. If direct pressure fails or is inappropriate, apply a tourniquet, rapid transport, and consider the need for ALS. Internal bleeding. Damage to internal organs and large blood vessels can result in a loss of a large quantity of blood in a very short time, and you won't see it. Your abdomen and pelvic cavity can hold all of your blood, all of it. Um, Seen it. It's a mess. Severe blood loss can result from injuries to the extremities, mostly hips and shoulders, is and neck injuries is where this comes from. Is a separation of the femoral artery, the subclavian artery, or the carotid arteries. Um, Mechanisms of blunt trauma that may cause internal bleeding: falls, MVCs, autopeds, and explosions. Um, the one that most people seem to overlook and think is not quite as severe as falls. 40 fall, probably not. 90 fall on thinners, maybe. Um, Penetrating traumas, obviously there's going to be internal damage, especially if it's a significant penetrating trauma. GSWs, stabs, or shrapnel from some kind of explosive device. If you start to see it, you'll start to see swelling around whatever area was affected. Some swelling to the abdomen, rigid abdomen, liver lack, spleen lack, all of the things, aortic aneurysm, be concerned about those. Bleeding from the mouth, rectum, or vagina. So all of those are mucous membranes. Every mucous membrane in your body is semi-permeable, which means with enough pressure around it from something either inside or outside, it will leak through eventually. Um, Tender, rigid, or distended abdomen, vomiting, coffee ground-like substance, or bright red blood, dark tarry stools, or bright red blood in the stool, and signs and symptoms of shock are all going to be some of your leading indicators of some form of internal hemorrhage. That's a decent picture of what was probably a broken shoulder with a blood pressure cuff on it. Leave that there. Patient care for these patients. Obviously, we're going to maintain our ABCs. Consider the need for high concentrated oxygen, simply because we don't want our patients to become hypoxic, hypothermic, which leads to coagulopathy. We're going to control any external bleeding as best we can, apply a splint if needed, take our steps to prevent body temperature, and rapid transport to an appropriate medical facility. Early signs of shock, typically, I wouldn't say restlessness, but more anxiety, pale skin, and rapid pulse, and tachypnea or rapid respirations. If it remains uncontrolled, if you don't do anything to intervene, that's when a patient's blood pressure falls. And that's the last thing in compensation before you become to decompensated shock. Once you have a decrease in blood pressure, you are in decompensated shock. Elderly patients. Elderly patients typically don't present like your average 30-year-old patient. Anybody know why? Don't everybody answer at once. All right, most of your patients are taking medications to control their heart rate, whether they have an uncontrolled heart rate or hypertension. A lot of the medicines that are prescribed to those patients inhibit the ability's body to compensate. So if you have a hypotensive patient whose blood pressure or whose heart rate is normal and they look like crap, they're probably in shock. Their body's just not able to compensate. We're going to maintain the airway, prevent hypoxia, control the bleeding, and keep our patient warm to the best of our ability. I'd say probably 80% to 90% of all external bleeding can be controlled with direct pressure, with the exception of small arterial bleeds. When they don't work, switch to a tourniquet or a hemostatic dressing if it's from the head or the torso. Emergency care for internal bleeding is based on the prevention and treatment of shock. So the only thing that we can do for internal bleeding is refill the tank, keep them warm, keep them calm, and help them breathe. I don't know if you know this or not, but oxygen is an amazing vasoconstrictor. um, can't press this enough. One of the most important treatments is early recognition of shock and immediate transport to a hospital, an appropriate hospital. Circulatory system is designed to ensure adequate perfusion of all body tissues, whether it be skin or organs. Classification of hemorrhage is directly related to the vessel ruptured and the pressure within the vessel. Low pressure system is the venous system. High pressure system is the arteries. And what separates the two is the capillary beds. Shock develops if the heart fails, blood volume is lost, blood vessels dilate, all resulting in inadequate perfusion. Signs of shock reflect the body's attempts at compensating for inadequate perfusion. What that says is your patient who is tachycardic, tachypnic, pale, cool, and diaphoretic, who just fell off of a ladder, is showing signs of compensated shock. They're not hypotensive yet, but they're still in shock. Most important treatment is rapid transport to definitive care. Treatment of external hemorrhage, direct pressure, wound packing, hemostatic agents, and tourniquet application in that order. Obviously, if you denote a severed limb that has an arterial bleed, we're going to skip the preceding and go to a tourniquet because that's appropriate. Internal bleeding is almost impossible to evaluate. Most important treatment for somebody who you suspect has internal bleeding is transport to a facility who can diagnose and treat said possible injuries. What can you use that you have on your body that will control bleeding but not damage tissue? More than likely, most people have a belt, and that's probably the only thing that it can be used as a modified tourniquet. Otherwise, try to resort to commercial grade tourniquets. This is something this is a question that I pose to a lot of people because a lot of people like the stay and play mentality. But there's only so much that we can band-aid before they need a surgeon, right? What should you do at the scene and what should you do on your way to the hospital?
Keep the patient warm.
Okay. Biggest one is address life threats. Open airway. Well, stop bleeding. Open airway. Assist ventilations. Everything else can be done on the way to the hospital. Venous bleeds. Take care of that on the way to the hospital. Capillary bleeds. Take care on the way to the hospital if you get to it. Biggest thing is prevent hypoxia, prevent hypothermia, which promotes the clotting cascade. I want somebody to answer this question for me.
Will you ask it one more time, Wayne?
So I want somebody to read. Can you see the slideshow? If you guys haven't been able to see the slideshow, this has been an epic fail on my part.
I was on the wrong screen.
Okay.
We'll say he's in shock.
Okay. How does that change your assessment and decision making?
Shock is a life threat. Treat the life threat and move on to the next.
Perfect. Also, take a look at the surroundings. Look at the scene size up. Clarifying questions. You know, if the patient's a poor historian or isn't able to tell you what's going on, look at the scene. If you're on the front porch, there's 5 steps coming down the porch. Front door's open. It's cold outside. Patient doesn't know who he is, where he is. We could probably deduce that there's a good possibility he fell from up there and has been out here for a while. So scene size up. Um, is there anything else that you would look at to determine whether they're in shock versus just have an anxiety attack?
Check for major bleeding.
Okay. Okay. Signs of trauma, right? Scene size up, full patient assessment. Major concerns in this scenario.
One of the concerns I see is the steering wheel and the column and the steering wheel are badly deformed. There's no external bleeding, but there could be possible internal bleeding.
Okay. Well, we covered it earlier. The number one cause of internal bleeding is blunt trauma. It's good. Is anything in those vital signs concerning?
The pulse of 116 and respirations at 20
Okay. What else?
and the lower blood pressure.
Okay, you're trending, you're headed downward, right? This patient's probably compensating. How much longer are we going to compensate? The last thing that goes is the blood pressure. It's an okay-ish blood pressure now, but how long do we compensate? What about listening to lung sounds and heart sounds on this patient? Chest trauma.
Yes.
Yeah, absolutely. So, your blunt chest trauma patients have a tension pneumothorax or cardiac tamponade until proven otherwise. There's nothing that anybody can do pre-hospital for a cardiac tamponade except for get them to the hospital. We can potentially identify it, which may expedite the patient's care. But tension pneumothorax is absolutely something an ALS unit could take care of. So just something to consider if you're ever in a system that works a tiered 911 response system and you're working a basic truck. This patient, even though 116, that's not bad. That's double entry level normal. Respiratory rate of 20. He's breathing fast and shallow, more than likely. 1, it hurts. 2, maybe he can't breathe that deep because one of his lungs is collapsed. Blood pressure 106/70. How old was this patient? Didn't say. Could be normal. I'm leaning towards on the low end of normal. This patient's in compensated shock until proven otherwise. Those are all appendixes. I have got to step away for just a minute. And as soon as I start the next PowerPoint, give me about 6 minutes and I should everything else have chapter 30 ready.
Hey, Wayne, real quick. With that internal bleeding, will it ever start to look like lividity before?
Not before they're dead.
Okay.
Once it's created enough pressure to start seeping through the skin, like I told you, a majority of adults, their pelvis and abdomen can hold the entire contents of your vasculature. So it would take, I think the last time I read, I think it's 12 liters of blood to create enough pressure to start forcing blood out of the skin. Because especially in the abdomen and chest, you got to think you're going through the abdominal walls, the obliques, the adipose tissue, and then all of the layers of the dermis. to get out. So you've got all of that to get through. Now, if you've got blood leaking, like it said, from the vaginal cavity, the mouth, or the rectum, you got a problem. I'm gonna go grab something to drink. Give me like 2 minutes. Is everybody back?
Yep.
Team 4.
I'm here.
Yep.
Here we go. Um, here. All right. So topics for this chapter: soft tissue, closed wounds, open wounds, how we treat specific types of open wounds because they are a little different. Burns, electrical injuries. When we talk electrical injuries, we mean big stuff, and then choosing dressings and bandages for each injury. Soft tissues, skin, fatty tissues, muscles, blood vessels, connective tissues, membranes, glands, and nerves. So basically everything from the skeleton out. Soft tissues is everything from the skeleton out. Um, some of your internal organs can be considered soft tissues, but the majority of your soft tissues is skeleton out. Um, I don't I don't know if they still teach this or not. Um, but the skin is the largest organ on the body, comprising of like 21% of the body weight or something like that, 18% of the body weight. Um, its biggest job is protecting you from all of the nasty outside. Its next biggest importance is water balance. That's why we sweat. That's why we don't sweat. That's why when it's humid outside, we also get wet because our body is utilizing that moisture in the air to try to regulate internal water balance. Temperature regulation, excretion, and then padding, impact resistance. Because if we didn't have skin and the ability to bruise, we'd have way bigger problems on this planet. So skin layers is epidermis, dermis, and subcutaneous layers. The epidermis is the outermost layer of tissue. It's what's exposed to the elements on a regular basis. That's what gives you your suntan. The dermis is directly under that. It's where a lot of your hair follicles and your pain receptors and all of that are. And then the subcutaneous layers, it's where a lot of the fats are. And your veins and arteries. Sorry, your veins and arteries, and then your capillaries tend to be in the dermis. So the epidermis, like I said before, that's the outermost layer. It's the outermost layer is dead skin, and then you've got slightly less dead skin until you get into the sensory receptors in the dermis. Um, Hair follicles reside in the dermis, right there at the very base of the dermis, but they're there. And then so the subcutaneous layers, that's where your sweat glands are, and that's where your nerves, veins, arteries, and then also your the lymph nodes live in the subcutaneous layer as well. Closed wounds, internal injuries with no pathway from the outside of the body to the injured site. The skin may be unbroken. You may be damaged tissue underneath. Range from I smashed my thumb to I crushed my leg with a truck. You may not open the tissue when you run yourself over, but it still may be an injury, a life-threatening injury. Closed wounds are typically present with contusions, also called bruises. Hematomas, they're similar to a contusion, but they accumulate blood under the tissue and they cause more tissue damage because that blood accumulates under the tissue and it creates pressure to not only the tissue above the hematoma, but also below it. Those usually involve larger blood vessels, so that's going to initiate in either the subcutaneous layer or even down in the muscular layer. Force closed crush injuries, force transmitted force from exterior to internal structures, and they cause crush or rupture internal organs, including muscles. Solid organs bleed severely and cause shock, where hollow organs leak into body cavities. So I mentioned it before, liver lac or spleen lac or spleen rupture, those are two solid organs. Those bleed a lot. Where you can have a ruptured stomach and you can leak gastric contents or even a intestinal rupture, and those contents can leak into the abdominal cavity, causing severe infection. Contusion, internal laceration, injury of a solid organ. I kind of covered all of those. Questions? Patient assessment. Bruising may an indication of internal injury or internal bleeding. Biggest one is mechanism of injury. We've talked on it before. Small fall, standing to a floor is going to be way less damage than somebody getting hit by a car. Consider your mechanism of injury when you're looking at the external versus considerations for internal injuries. Crush injuries are difficult because especially if the patient gets crushed for an extensive period of time. The body knows that that pressure is still there, so it's going to rush fluids to that site, that intrusion site. And as soon as it's released, not like at the blink of an eye, but pretty quickly, that crushed area is going to fill with fluid. And it's going to be hard to tell what all in that area was crushed because it's going to be filled with all of this plasma and white blood cells and all of the things that the body's trying to do to fix it will make it really hard to identify how extensive the injuries are. Obviously, BSI, we've pounded that into your head for the last 3 weeks. I'm pretty sure you're tired of hearing that. Standard precautions: manage their airway, breathing, and circulation. Always crush injury patients have internal bleeding until proven otherwise. We're gonna take them to a trauma center that has surgery capabilities sooner rather than later. Once we've initiated transport, we're gonna splint extremities that are painful, swollen, or deformed. If they throw up, obviously position of the recovery position if you're capable of doing so and they don't have any spinal injuries, otherwise airway suctioning. All of our patients need vital signs checked at a minimum of every 15 minutes. If you suspect shock, every 5. Cold packs to isolated injuries to manage pain and swelling. That's pretty heavily important. Open wounds. An open wound starts at an abrasion. Everybody thinks that if the bone's not sticking out, it's closed. Well, as soon as the skin, if there's any separation of skin and there's bleeding, it's considered open because that outermost layer, the epidermis, has been damaged and we're down into the dermis. The dermis is where infection happens. Once you've broken that protective layer, it is now considered an open wound. So abrasions, lacerations, penetrating trauma, avulsions, and amputations are a short list of types of open wounds. Open crush injuries, bite wounds, blast injuries, or high pressure injection injuries. I don't know if there's any, I mean, you can come across it, any piece of equipment that runs hydraulics, but hydraulic high pressure injection injuries are interesting. Question: does an open wound necessitate using more than just gloves as standard precautions?
It can if it has foreign body contaminants in it.
Yeah. Or if it's an arterial bleed. Like, I don't know about you, but I don't want somebody taking their forearm that's a sprinkler and spraying me in the face with it. What about a face shield? It's not out of the question, right? Can an open injury affect a patient's airway or breathing?
Depending on where the injury is at, yeah.
Absolutely. Broken jaw, crush injury to the face. Absolutely, it can. There it is. Strict attention to standard precautions. Gloves are a necessity. Gloves, gown, and protective eyewear may be required. It all just depends on the type of patient you're taking care of. As with all of our patients, we're going to take care of ABCs, the airway, breathing, circulation, any kind of severe bleeding. Going to stop all arterial bleeds first, and then we're continue care for individual wounds. Obviously, we're going to expose it, do what we can, control the bleeding. We're not going to take out the soap and water. We're not going to take out the Hibiclens, and we're not going to make it ready for stitches. Wipe it down, get all of the external contaminants away from it, wrap it up, control the bleeding. If your patient is showing signs of early shock, treat for shock. Keep them warm, keep them oxygenated, get them to the hospital. The idea is prevent further contamination. Obviously, if they're bad enough, they're getting antibiotics at the hospital. But we still got to try to keep it from getting worse. So once the bleeding is under control, you can bandage the dressings in place. Do what you can to keep your patient from moving. The more they move, the more the dressings move. The more the dressings move, the more they're going to start bleeding again. Coach them, talk them through everything you're doing, reassure them that you're doing everything possible to help them, and you're going to get to them to a doctor and possibly a surgeon if they need it, okay? Abrasions and lacerations are what we deal with the most. Abrasions and lacerations require the least treatment possible, or the least quantity of treatment. Reduce wound contamination. Obviously, don't drop a 4x4 on the ground. Pick it up and put it on your patient's leg. Try to use a sterile gauze, cover the wound, direct pressure to control the bleeding. Check CMS, circulation, motor, and sensory post the application of your wound control, before and after you apply it. Penetrating trauma. If whatever they're stabbed with is still in them, leave it. Because it could be deeper than it looks. The last thing you want to do is to grossly pull something out and nick an artery that was not nicked on the way in. Okay. Bullet wounds, check for an exit wound. It's one thing that I see a lot of people overlook. They'll find the entry wound, they treat the entry wound, but they forget the exit wound. There's a hole in the front of the chest and a hole in the back of the chest. We have to close both of them so that the lung will reinflate. Okay. Bullets hit bones, they turn bones into splinters. But that's nothing that we have to deal with. That's a surgeon problem. but it's good to identify as to what bones could have been damaged. Any stab wound between the chin and the pelvis is life-threatening until proven otherwise, because I cannot see inside, and there's so many things that can be bleeding. Calming your patient's the easiest thing that you can do, and probably one of the most therapeutic things you can do for somebody is to reassure them and calm them down. Search for the exit wound as best you can. Assess needs for basic life support, and then if needed, spinal motion restriction. That they're talking C-collar and backboard. I could be wrong, but I do believe the new standards is as long as the patient's compliant, unimpaired, and has no neurodeficits, C-collar suffices, and you're not required to backboard. I'm not sure that that's the National Registry standard yet, though. So don't take my word on that. Refer to your book on that one, because that's changing. And then obviously transport the patient. They've got holes in their body. They probably need to go figure out what all was damaged and why. Anyone here a hunter? You're a hunter, you understand that bullets don't travel in straight lines once they strike a semi-solid object. That bullet can be deflected by fat. It can be deflected by ribs. It can be deflected by you name it. So just because the entry wound on the back of the chest appears to be above the diaphragm doesn't mean that didn't hit damage or do damage to the diaphragm or below the diaphragm. That's the importance of finding the exit wound, because that will give you a rough trajectory of what was damaged between the two holes. That looks like an exit wound that probably came in from the right flank. Where's your diaphragm? Where's your diaphragm sit?
Right there below your sternum.
Right there, right? So that's the xiphoid process. So depending on where the entry point is on this very well could have transected the diaphragm. Impaled objects. Don't remove it. I think I covered that. Can make the bleeding worse. Expose it as best as you can. Get a description. You know, if it's a kitchen knife, have them explain to you roughly how long the blade is, et cetera, et cetera. Don't pull it back. Yep, that's how big it is. Put it back in. Let's not do that. Control profuse bleeding if you can. And then apply several layers of bulky dressing so it surrounds it and keeps it uniform to the body moving. So once you've got it somewhat secured, tape that whole bulky dressing down to the patient's body as best as you can. It's not always going to be easy, especially on your thinner patients. Just packing all that gauze is difficult, and then getting it all taped down is also difficult, especially without moving things. But that's key in your impaled object patients. Treat them for shock. Keep them at rest. Don't let them move themselves unless it's like in the calf or the forearm or whatever. You can splint that extremity, keep them from moving that extremity. If it's central core, you do all of it. And then obviously talk them through it. Tell them everything that's going on.
Wayne, I got a question for you real quick.
Yes, sir.
On an impaled object such as a post or like a T-post,
Yeah.
and as firefighters having to cut that off before we move the patient, how would you bandage around that? Just out of curiosity.
You're not going to bandage that until they're off, because the last thing you want to do is get in their way. Because ideally, getting them getting them from where they're at to your cot is going to be better for them than you interfering with them cutting the post.
Okay.
So your treatment of that impaled object begins once they're no longer secured to the ground or the vehicle or the building or whatever they're impaled with is attached to. So the idea behind stabilizing an impaled object is to minimize the damage once you assume patient care. Because, I mean, unless it's an arterial bleed, and let's be honest with you, if you've got an arterial bleed and you've got a T-post through your abdomen, there's nothing I'm going to do for you. There's nothing you're going to do for them. They needed a surgeon to be standing right next to them when this happened. It's to minimize the quantity of damage during transport. Um,
Hey,
and
wait, I got something that kind of adds that kind of a question.
yeah,
Would let's say cutting that T post or a wood post or whatever, cutting that post, would it add damage to what's already been done?
yes, it will. It 100% will. But just grossly jerking that through the body is going to cause more damage. Obviously, you're gonna work with whatever fire crew you're with and talk them through, be like, hey, I understand we want to get this done, but we need to cause as little movement as humanly possible in this object that they are impaled with. So maybe have somebody hold it above them and just below it. Because you can have, so say it's a abdominal impalement, you can have that object stick out both sides and lay the patient on the opposite side of their abdomen in which that they're impaled and secure it that way. So it doesn't necessarily on whichever side that they're cutting it from doesn't have to be cut body level. And you really don't want to either because you want to leave space, a cushion, so you can track and make sure it's not moving. But a majority of the time, and I'm not saying that it's going to be impossible, but a majority of the time that you're going to deal with impaled objects, it's going to be somebody stepped on something, somebody stabbed somebody in the eye, or I have something stuck in my arm or leg. It's most of the time when you're going to be dealing with an impaled object. It's just a good representation of what a good bulky dressing around an impaled object would look like. And don't be afraid to use gauze. Gauze is cheap. We got plenty of it. Impaled objects in the cheek, they may enter the oral cavity, causing an airway obstruction. If the cheek wall is perforated, profuse bleeding into the mouth or throat can cause nausea and vomiting. Recovery position. Um, External wound care will not stop the blood flow into the mouth because if you we talked about it earlier, the mouth and the vaginal cavity and the rectum are all mucous membranes. Rectum, sorry, are all mucous membranes, and they're very vasculature. They're very vascular. All your mucous membranes are. They're designed to keep moist and to absorb nutrients. That's their job. Well, which means they require a large quantity of blood vessels. So if you have something that perforates the cheek, then bleeding control from both sides of the wound is necessary. Um, if you can see the perforation of the cheek, this is the one time that you're allowed to remove something because it allows it helps in bleeding control. If you can see the perforation and you can see both ends of the object, you're allowed to remove it. I gotta move myself. If you can't, leave it in place. Um, the process of removing it from the cheek is you have to guide it. You have to be able to feel inside the mouth and feel where that object goes, and you have to find the end of it. If you can't find the end of it, it has to stay. Um, Position them where the blood's going to draw. So if it's on the right side of their right cheek, lay them down on the right side and work it that way. Um, if you get it out, dress the outside of the wound and have them keep their mouth closed and have them and apply direct pressure. And obviously any patient that we are worried about trauma, we're going to consider the need for oxygen and care for shock. Puncture wound or an object impaled in the eye. So stabilize it, apply some form of rigid protection, and then cover both eyes. So that's the recommendation for securing the object in the eye. And then you're going to take a rigid cup or something around that to keep from bumping it. So why would we want to dress and bandage the uninjured eye?
Because of sympathetic movement from the other eye.
Yep, exactly. Where one eye goes, the other one follows, right? They're attached. And if they're moving around, that impaled eye is going to incur more damage. So the idea is cover both eyes, tell them not to be trying to look around, tell them that you're going to do everything for them, you're going to guide them, you're going to explain everything, you're going to do everything possible to help them be comfortable through that transition. Obviously, if it's just isolated to the eye, yeah, if they're in some form of shock, it's going to be mild, but we're still going to treat them for that. The optic nerve does have a channel that runs through the skull, so it's not out of the question that whatever object is impaled in the eye could have made it to the brain. Avulsions. So, clean the wound surface, fold the skin back into the normal position, control the bleeding, and dress with bulky dressing. If they're completely torn away, save in a sterile dressing and keep moist with sterile saline. Questions about that? Okay. Amputations. Obviously, we're going to do what we can to control bleeding. Tourniquets if necessary. Um, Direct pressure. Obviously, we're not going to put direct pressure on a bone end. That's not appropriate. Fingers will self-shunt pretty quick. Anything above the wrist or above the ankle, it's not going to self-shunt real quick. Those blood vessels and arteries are too big. Those are almost always going to require some form of tourniquet or some form of really, really heavy pressure dressing to control bleeding. Wrap the amputation in sterile dressing. Secure the dressing in self-adhesive gauze bandage. Um, Bag it in a plastic bag and keep it cool with a cool pack. Do not immerse it directly in water or saline. Keep it dry. Genitalia control bleeding with direct pressure. We don't put anything inside. Preserve avulsed parts, just like we would with the avulsion before. Is it worse than it looks? If it probably is. Be calm, dress the wound, and if a lot of times your genitalia trauma are caused in the wake of some form of sexual assault, unless it's, you know, somebody got thrown off their motorcycle and landed on a wrought iron fence. Uh, Burns. Burns are not as simple as people like to think them are. A lot of times, if a person has a second degree burn, they have several first degree burns. If they have a third degree burn, they have several second degree and several first degree burns. It's going to be a lot of math on your part. And third degree burns and even fourth degree burns go deeper than just skin. Um, all of the places that you get burned are going to swell. So if somebody you're taking care of has quite possibly inhaled during whatever fire, their airway will likely become compromised due to swelling. Um, Obviously, we're going to assess for neurodeficits, spinal damages, etc. How they classify burns is what caused the burn, the depth of the burn, and the severity. Chemicals, electricity, or just heat. Um, Obviously, if you're able to identify um, what caused the burn and let the receiving facility know, that way they can treat the patient appropriately because chemical burns, each chemical has a different antidote. Um, and then electricity needs to be treated a little differently than a chemical burn. Never assume you know what it is. Um, Obviously, do your best in doing a good scene size up and utilizing all of your resources on scene, bystanders and company people if they're there. So this is what used to be first, second, and third degree. It's now superficial, partial thickness, and full thickness. Superficial is your sunburns, your wind burns. I put my hand on something, no blisters. Partial thickness is they'll be blistered. Um, Underneath those blisters is just the regular layer of skin. Um, Full thickness burns, there's typically a blackened look to the skin, or a whitened look to the skin, depending on how hot the burn was. There will be blisters, there will be skin sloughing, and there's a lot of times portions of that burn will be numb because it burned the nerves. Um, so partial thickness, epidermis is burned through, the dermis is damaged. These are typically your most painful burns. Noticeable redness, blisters, and mottling. That's going to be a good representation of a second degree or partial thickness burn. So is that. Third degree burn is all layers of skin, blackened areas, and or white patches. Um, that's a good representation of a good third degree. That's probably an electrical burn. Um, a lot of things that need to be information that needs to be gathered fairly quickly is what caused the burn and what do we need to do to stop the burn. What portions of the body are burned? How depth is it? How deep is the burn? The extent of the burn and the age of the patient. Age of the patient is going to determine a lot of things, especially with treatment goes. Once they make it to the burn unit. A lot of your elderly patients don't recover well from big burns because their immune system isn't quite as good as it used to be. Um, the burn isn't what gets them, it's the infection that subsequently follows because you lose your body's ability to prevent or reduce the risk of infection. The rule of nines helps estimate the extent of a burn area. It doesn't have to be perfect, but it needs to be close. An adult body is divided into 11, excuse me, main areas, which represent 9% of the body surface area. So I like to teach people that the head is 9, the arms are 9, the front and back of each leg are 9, and then the chest and back is 18, and then the genitalia is 1%. It does change for infants and newborns, or infants and children, um, a little bit, mostly in the legs, and head. I would study this. This is typically tested pretty heavily on. Are you guys given copies of this presentation?
Like paper copies, or
Or just access to the PowerPoints, or is this in your books?
he uploads them to YouTube.
Okay, perfect. I would study the rule of 9. It's actually pretty useful. All right. The rule of palm is another way to identify smaller or estimate the extent of smaller burns. Um, the palm and fingers equal about 1% of your patient's body surface area, not your palm and fingers, their palm and fingers. Um, so, but you need to classify your burns because first degree burns or superficial burns typically aren't going to require a burn center, um, unless they're widespread. But typically superficial burns. Ever been put in a burn unit for a sunburn? Don't think so. Second and third degree burns are where we start to really worry about infection because the dermis is damaged, right? The dermis is the internal layer of protection. That's going to determine your priority for transport. Anything with head, neck, chest, or airway involvement, post-haste hospital. And then the maximum information available to provide to the hospital, especially if it's more than just fire, if it's chemical, or electrical. I covered this a little bit. Infants and children have a much greater relationship of body surface area to total body size, typically simply because their heads grow faster than their bodies, and they lose heat faster. We all know this. That's why kids get sent home in blankets from the hospital. That's why you're not supposed to keep them outside for greater than 3 hours when they're really little, especially when it's cold or hot outside. It's nothing new. Same goes for burns. The difference is once a baby is burned, their thermal regulation goes completely out the window. Um, Patient care for thermal burns. Briefed on this. Stop the burn. Cool the burned area if you can. Ensure an open airway and assess breathing. Look for signs of airway injury. That's gonna look it's gonna look a lot like the sunburn, but on the back of the throat, or charring around the nose and soot in the back of the throat. Those are all signs of potential airway involvement. Complete your primary assessment, your ABCs, and we're going to treat every burn patient with whether they're showing signs of it. We're going to treat them for shock. Oxygen if needed, keep them warm. Warm's the big one. Evaluate the burns by depth, extent, and severity. Try not to brush stuff away because the body will slough. The body will get rid of what it wants to get rid of. It'll keep what's viable. If you're capable, remove clothing and jewelry. Wrap your patient in a dry, sterile dressing and then cover them with a blanket. Hands and fingers and toes. Put sterile nonstick gauze between each finger before you wrap them, because once they become leaky, those fingers will actually stick together. It's pretty painful. Um, chemical burns. This is where our fire department gets involved, and we're gonna have to decon them. Copious amounts of water. Dry chemical, remove contaminated clothing, and then flush with water. We're not gonna wash them in their clothes. So most of your chemical burns are gonna be treated with copious amounts of water. Um, chemical burns are treated no differently than regular thermo burns. Dry sterile dressings treat for shock and transport to an appropriate facility. To my knowledge, the only burn center we really have is children's. Um, to my knowledge, they don't accept direct admits. So we're gonna have to take them to the closest trauma center, and then they will transfer them if necessary. Um, Radiation. This is something that I'm not super familiar with, and I don't read up on it as much as I probably should. Um, but radiation does cause burns. That's actually how they use it in cancer. The radiation just burns the tissue. Exposure to high levels of radiation can cause the human body both immediately and in a delayed fashion. Um, Problem with radiation is it's hard to detect without specialized equipment. Radiation is one of the a higher cause in cancer. It also is a significant cause in burns and deformities in kids. Um, all patients who have been exposed to radiation have to be decontaminated with by somebody of a hazmat team. And I don't know if we have one locally that does radiation decontamination. I don't. Electrical injuries are unique because they not only burn you where the electricity enters your body, but they also damage everything in between and then have an exit wound. Um, Respiratory and cardiac arrest are possible. It depends on the path of the electrical travel. Um, I've Higher voltages can cause um, broken bones from violent muscle contractions. ABCs are just as important in these patients as anyone else. Probably a little bit more important. Be prepared to any electrical shock patient. Make sure you have an AED with you, if possible, and be prepared to work them as a cardiac arrest. A lot of these patients are going to be in a shockable rhythm for a long period of time after the introduction of electricity. If they're not in cardiac arrest, we're going to treat them for shock, administer oxygen, keep them warm. Um, Spinal precautions are fairly important in these patients, primarily neck, because usually they get thrown and or dropped and will hit their head. Evaluate the burn sites. Typically, they're fairly small, unless their whole hand was touching something. Cool the burning areas. Cut clothing off, the same as you would for a flame burn. Apply sterile dressings and transport as humanly possible. These patients can be in cardiac arrhythmias or dysrhythmias for several days post electrocution. Dressing and bandaging. Any dressing is something that is applied to a wound, control bleeding, and prevent contamination. A bandage is a material used to hold a dressing in place. Universal dressing available for profuse bleeding, large wound. Pressure dressing, controlled bleeding, occlusive dressing, usually used to form an airtight seal. Wounds to the abdomen, large neck veins, and open wounds to the chest. Penetrating chest trauma, abdominal avulsions, things like that, we're going to use an occlusive dressing on. Just a representation of dressing and bandages. Patient care. Dressing open wounds. Take standard precautions, expose wounds. Use these sterile or very clean materials. Cover the entire wound. Control bleeding with direct pressure or hemostatic agents, or dressings to stop or slow bleeding. And once you do, don't remove your dressings. Don't bandage too tightly or too loosely. Don't leave any loose ends because the last thing you want to do is to catch and tug on all that stuff. Um, Don't ever cover the tips of fingers or toes, because that's one of the things that you can check for circulation is capillary refill, um, and that'll tell you how um, tight or loose your dressings are. Um, um, Roller gauze application is pretty straightforward. Soft tissue injuries are usually closed, internal with no pathway to the outside. Sometimes they can be open, in which an injury breaks the skin, exposing the tissues below, whether it be muscle or bone. Closed injuries most commonly are bruises. Second commonly are hematomas. Um, Crush and blast injuries are um, probably some of the most deadly things that you'll ever deal with, but are underrated because they look fine when you get to them. Open wounds start at abrasions and lacerations because that layer of skin has been broken. Once that layer of skin has been broken, it's considered an open wound. Punctures, avulsions, amputations, crush injuries, and blast injuries. For open wounds, we're going to expose it if it's safe to do so. Observe the wound and address it accordingly. Control bleeding and prevent further contamination. We're always going to use our PPE, primarily gloves, and if mechanism of injury says so, we need to wear face shields and maybe a gown. Note the mechanism of injury, what caused this patient's trauma, protect the patient's airway breathing, and consider the need for oxygen. Treat for shock and transport. Treating for shock is preserve temperature, limit hypoxia, and um, reduce changes in coagulopathies. Burn severity is determined by considering the source of the burn, the bodily regions burned, depth of the burn, extent of the burn, age of the patient. As I said before, kids and adults react more severely. And then if the patient has any other underlying illnesses or injuries. Care for burns is stop the burn, obviously. Water for thermal burn, brushing away dry chemicals, covering a thermal burn with a dry sterile dressing, flushing a chemical burn with sterile water, protect the airway, administer oxygen as appropriate, treat for shock, and transport the patient to an appropriate trauma facility. For treatment of electrical injuries, be sure that you and the patient are in a safe zone away from the possible contact. Protect the patient's airway, breathing, and circulation. Be prepared to care for respiratory or cardiac arrest. Treat for shock, care for burns, and transport the patient to the closest facility. Soft tissue is basically everything from the bones out and most of your organs. The skin provides protection, water balance, temperature regulation, excretion, and shock absorption, i.e. padding. Open or closed in reference to a soft tissue injury is dictated by whether or not the skin is still intact. So if there's bleeding, it's open. Closed injuries must be evaluated with consideration to underlying anatomy and mechanism of injury. Obviously, if the patient has a hematoma and a contusion to their chest, I'm worried about their lungs and their heart as well. Same goes for their abdomen. I'm worried about their liver, their spleen, their pancreas, their stomach. Open injuries are the ones that we see. They're easier to visualize. They're even easier to see, like, yep, that's the problem. That's what's broken. We can fix it. But they typically mask underlying injuries. Burns involve immediate destruction of tissue, but also can have long-term effect, both physically and emotionally. Being a survivor of a significant burn, it takes a toll on you. Safety must be a key concern when treating a patient with a burn, primarily electrically or chemical. Keep yourself safe. Don't expose yourself to a chemical and create patient two. The whole reason we dress dress and bandage wounds is to control the bleeding and prevent infection. Obviously, what we do is not sterile, but something is better than nothing. Um, Things to ask yourself when you're assessing a trauma patient: does the patient have a patent airway, and are they breathing correctly? I mean, if they're not, then we got to stop and fix that. If the wound is penetrating, is there an exit wound? There's an exit wound. We need to address both sides. Oh, goodness. And then what is the best way to immobilize an impaled object? It's not going to be cookie cutter. Both are one way is not going to work for everything that you come across because you're going to have pencils and you're going to have T-posts. What you use to stabilize a pencil is not going to work to stabilize a T-post. And whatever you utilize to stabilize a T-post, it's going to be too large and cumbersome for the pencil. So adapt to the injury. Biggest concerns for burns for me is respiratory involvement. Second is if there's the quantity of burn. Um, have you irrigated the chemical burn sufficiently? Have you removed the agent that's causing the burn? Are you exposing yourself to being a potential burn patient? And then does the electrical burn have an exit wound? Typically, your exit wound is going to be bigger than your entrance wound because the electricity is trying to escape in the path of least resistance, and it usually takes more than one path. And then are we bandaging securely to hold the dressing in place? More times than not, more often than not, you'll have a bandage and a dressing just sliding down a patient's arm because, well, I didn't want to put it on too tight because I didn't want to cut off circulation. Um, so 21-year-old male lacerated his anterior elbow when he fell through a window. There is a lot of blood around the patient. Bystanders have applied numerous towels and washcloths over the wound. How do we treat this patient? We still got to see it, right? Our towels and washcloths, bandages. God,
No, they are not bandages.
no, they are not. So many dressings on the wound that you can't tell if it's still bleeding. The patient is alert but pale and anxious. The radial pulse and his uninjured arm is weak and rapid. How much assessment of the wound should you do, and how would you do it without making things worse? Depending on how long how long ago it happened, obviously clotting factors begin the minute something is put on there and pressure starts. So obviously you can keep trying to apply pressure and or switch to a tourniquet. Me personally, we teach not to remove bandages, but in a situation like that, you need, in my humble opinion, you need to see what's best for your patient. Doesn't take but a couple of seconds to look at something. We're like, yep, that's bad, tourniquet. Or nope, that's just a regular pressure dressing, and we just couldn't apply pressure through the 3 inches of towels. If there's a large quantity of blood around him, I would lean towards an arterial bleed and apply a tourniquet and transport him to the hospital. Um, all the appendixes of. Can't find my mouse. That's this. right. We're gonna chug through this chapter. I'll take a couple-minute break and then we'll get to the last one pretty quick. Chest and abdominal trauma. Um, Chest and abdominal trauma are probably some of the most underappreciated / most deadly things that we deal with on an almost daily basis. The anatomy and physiology of the chest and abdomen. There's so much that goes on between the pelvis and the clavicles that gets overlooked on a regular basis. And all of it is needed for homeostasis. Without your lungs, there's no gas exchange. Without your heart, there's no circulation. Without your liver, there's no filter. Without your spleen, there's no uh, removal of waste red blood cells. Without your pancreas, there's no insulin. Like the list just goes on. Without your intestines, there's not appropriate absorption of nutrients. Like the list just goes on and on. um, the chest cavity extends from the collarbones to the diaphragm. Um, Everything above the diaphragm is considered the thoracic cavity, and everything below between the diaphragm and the pelvis is considered the abdominal cavity. The interesting part about the chest is the physiology changes. The pressure inside your chest changes every time you breathe, every time you talk, every time your heart beats. Packed with blood vessels, packed with organs. Lungs are large. Hearts are large, depending on how far into heart failure you are. Your aorta, your superior vena cava, your superior vena, and your inferior vena cava, your aortic arch, the subclavian arteries, the beginning of your carotid arteries, all that rests right there in the center of your chest. Your pulmonary veins, your pulmonary arteries, all those major blood vessels are there. That's why we have ribs. Go through all that, and that's why all of that sensitive those sensitive organs and structures are protected by ribs. That's why we have a sternum. That's why the thoracic spine, the thoracic vertebrae are the largest vertebrae in the body, because all of that stuff is so fragile. And then you add the scapula on the posterior aspect of it. It also protects the apexes of the lungs. Covered a little bit of the physiology of it. Heart produces blood flow. All of the blood vessels that enter and exit the heart are in that thoracic cavity. Also, all respiratory function happens in the chest cavity. It's a terrible illustration. Mechanism of breathing. Chest wall, diaphragm, and lungs all work together. Have you gone over what causes breathing? Hope you have. Changes in pressure within the chest cavity is what actually initiates you to breathe. We are inherently a negative pressure system. So when our body wants to breathe, the diaphragm pulls down, creating a negative pressure in the chest. That negative pressure inside your chest allows the positive pressure from the atmosphere to push air into your lungs. Breathing out is active. Diaphragm extends out, puts positive pressure on the lungs, forcing all of that out. Inhalation is an active process, uses negative pressure to draw air into the lungs. Exhalation's passive process uses positive pressure to push air out of the lungs. The anatomy and physiology of the abdomen. The superior border is the diaphragm. The highest portion of the abdomen is the diaphragm. The lowest portion is the pelvis.
The abdominal organs extend to the lower regions of the pelvis. Um, have have you guys gone over the 4 abdominal quadrants? You should have.
Yes, we have.
Okay. So, representation of solid organs on the left, hollow organs on the right. Solid organs include your spleen, liver, pancreas, and kidneys. Hollow organs are stomach, gallbladder, duodenum, large intestine, small intestine, and bladder. The reason that that's all important is if you think about it and you've got a patient that has right lower quadrant and left lower quadrant abdominal pain, are there any solid organs down there that can cause severe bleeding? No. There are no large arterial bearing solid organs in the lower portions of the abdomen. That doesn't mean they won't be bleeding. It just means the blood vessels feeding them are smaller. So you have mesenteric arteries, which can bleed a lot, but it's hard to damage those because they're fluid, they're not fixed. Um, Trauma assessment and care takes into consideration placement and function of the abdominal organs. Differentiate between hollow and solid organs. Hollow organs tend to tolerate trauma well. So your stomach, your intestines, since they're hollow, there's cushion. It can dissipate that impact better than a solid organ will. Um, each organ in the abdomen does its own thing. Um, um, Stomach processes food. You know, your GI tract does its thing. The liver filters and produces bile. The gallbladder produces bile. We went over what the spleen does. It does a little more than that, but that's a majority of its function. Pancreas is huge in blood sugar regulation. The abdominal cavity is dynamic depending on the location of the diaphragm. So you can change your pressure in the abdomen, same as it does when you're breathing, because that diaphragm separates the two. I think it's like 22% of the circulating blood in the body. It's either 19 or 22%, I remember. So it's a lot of your blood volume is in the abdomen at any given moment. And that's not like outside, that's just circulating in the abdomen because of the inferior vena cava, the abdominal aorta, the portal vein, the arteries, the renal arteries and veins, the mesentery, the all of the blood vessels in the feet of intestine that you have. There's a large quantity of circulating blood there doing all of the things that the abdominal organs are responsible for. Damage to the chest or abdomen can disrupt bleeding. Hemorrhage and shock is definitely not out of the question. Disruption of organ function is also not out of the question, and infection. I mentioned earlier that stomach contents leaking out into the abdomen typically causes infection. Same with the intestines. Chest injuries. Blunt trauma typically cause fractured ribs, sternum, damage to the rib cartilage. Penetrating traumas, bullets, knives, pieces of metal, glass, steel rods can damage internal organs and impair respiration. That's where tension pneumos come in. That's where cardiac tamponade comes in, was typically with penetrating traumas, or tension pneumos come from. Compression and shearing injuries occurs when severe blunt trauma causes the chest to rapidly decompress. That is typically when you're going to see a aortic tear or aortic dissection in the chest wall cavity, because the aorta and the superior vena cava, I wouldn't say that they're bolted to, but they're relatively well anchored to the tissues around the spine to protect them. But if they're, you can cause a shear and rip those structures away from the skeletal structures. Chest injuries are classified as either open or closed. Um, Rib fractures, typically not life-threatening as long as they're stable and aligned. Makes it hard to breathe because it hurts to breathe. Um, if they break inwards, they can lacerate lung tissue and cause um, pneumothoraxes. Flail chest is depicted as two or more consecutive ribs broken in two or more places. The reason that that's a thing is with all of the intercostal muscles and cartilage, even if you've got one rib broken in two places, the tissues on either side of it are going to keep it stable and keep it from shifting the sharp edges of that broken bone towards the lung. Once you compromise two of them, it creates kind of a floating segment of the ribs, and that can actually shift and puncture a lung. Um, Also makes the chest wall unstable, and it causes what's called paradoxical motion. What that means is when you breathe in, typically your chest wall expands, that segment will pull in. And when you breathe out, that segment will push out as your chest retracts. That's just a illustration of a flail segment. That's actually a really big flail segment. It's one, two, three, four total ribs. Um, with rib fractures, consider the mechanism of injury. Obviously, we're going to have pain and at the site of the injury and an increase with breathing. But what we need to monitor for is respiratory distress, hypoxia, or respiratory failure, signs of tension pneumo. Most of the time, patients that have broken ribs will be self-splinting. They'll pull their arms in and they don't want their rib cage to move. Allow them to do that. Let them be comfortable. Um, Flail chest typically takes a large mechanism of injury, unrestrained driver, motorcycle accident, auto pedestrian, a significant fall. Um, those are all high suspicion, index of suspicion for a flail segment until proven otherwise. Difficulty breathing, pain at the injury site, they're likely going to be hypotensive, tachycardic, and hypoxic because they're not breathing well. And then observe their chest wall. That paradoxical motion. Once you see it, you'll never forget it. Consider the need for ALS. Do they need needle decompression? Do they need just to get to the hospital? Allow them to remain in the position of comfort. Spinal precautions is needed. C-collar, depending on the mechanism of injury, maybe even backboard based on mechanism of injury. Treat the hypoxia with oxygen, and allow them to self-splint. Primary assessment for life threats, airway breathing circulation, and bleeding. If they're breathing inadequately, assist ventilation. We're going to assist them with a BVM as best as we can. If they're stable, request ALS for pain management. If you think it's necessary to get them to the hospital with analgesia, I think it's a good idea. I mean, I wouldn't delay transport for 20 minutes if you're 3 minutes from a hospital, but use your discretion. Don't restrict chest wall movement. If you put pressure on the chest, it's actually going to make it more painful and more difficult for them to breathe. Penetrating chest injuries, unless they use a hollow point, it's hard to determine entrance from exit. Any penetrating chest injuries are life-threatening until proven otherwise. Excuse me. Whew. With open chest trauma, the open wound allows air to get into the chest and creates an imbalance of pressure inside that chest cavity. That's why we need to seal the chest walls to mitigate the quantity of air that is between the ribs and the lungs to hopefully allow the lungs to reinflate. The shift of pressure from outside the body to outside the lung is actually what causes the lungs to collapse. The term in the description of an object that was penetrated, obviously it was a gun, it was a bullet. If one penetrating wound is found, look for others. Visualize the entire chest, front and back, and listen to lung sounds. Lung sounds on a healthy patient are hard to determine whether they're diminished or absent because of the echo in the chest wall cavity, in the chest cavity. Lung damage signs and symptoms is difficulty breathing, absent or unequal lung sounds, hemoptysis, or hypoxia. Does anybody know what hemoptysis is? It's coughing up blood. Other signs and symptoms are going to be shock, which is represented with tachycardia, tachypnea, pale skin, and low blood pressure. A sucking chest wound is classified as when air is drawn through a hole into the chest. It creates kind of almost like a vacuum sound for a split second, and then small air bubbles around the wound. Most of your patients that have a sucking chest wound are going to be gasping for air. Obviously, we don't want to try to make CMLS scene safe. Consider the need for ALS. Maintain and open the airway. We're going to use a chest seal as best as we can to seal the wound, and we'll apply occlusive dressing. Position of comfort is going to be different for every patient. We're going to utilize that. Administer high concentrations of oxygen. Treat for shock and transport. Treat for shock is going to, obviously, we already applied oxygen. We're going to keep them warm, and we're going to put them in the Trendelenburg position if necessary. Occlusive dressing seals are there to stop the movement of air. Flutter valve dressings involve taping a dressing in place and leaving a side of the corner of the dressing unsealed. As the patient inhales, the dressing will seal the wound. As he exhales, the free corner or edge acts as a flutter valve to release air trapped in the chest cavity. So it's hard to picture as you breathe in, it creates that negative pressure. It sucks that up against the wound, stopping air from coming in. And when they breathe out, as that diaphragm pushes up, it creates pressure inside the thoracic cavity. It's going to push that air that's around that lung out that hole. Does the patient's chest injury need to be treated during primary assessment? What chest injury needs to be treated during primary assessment? That's going to be your sucking chest wounds. Does the open chest wound require an occlusive dressing? That's going to be your sucking chest wound. Does your patient's injury necessitate immediate transport to a trauma center? Any penetrating trauma to the chest is rapid transport to a trauma center because nobody has X-ray vision in the back of an ambulance. Primary injuries, hemothension or pneumo, hemothorax and hemopneumothorax, which hemopneumothorax is basically just a mixture of blood and air around the lungs. Traumatic asphyxia, that's going to be trauma to the upper airway. Cardiac tamponade, which is blood or fluid surrounding the heart inside the pericardium, inhibiting the heart from being able to pump blood around. Aortic injury, those are typically a tearing injury from blunt trauma. Pneumothorax is when air accumulates in the chest cavity, possibly causing lung collapse. Tension pneumothorax is basically that air has accumulated to the point that it is inhibiting the ability to breathe and or pressure on the heart and lungs, inhibiting good blood flow. Tension pneumothorax and pneumothorax both present the same until you get to jugular veins. If you see tracheal deviation, that patient's probably not breathing, and they're seconds from dead. Patients will have diminished or absent lung sounds first, on whatever side's affected. Jugular veins distend next, and then tracheal deviation is the last thing before their heart is unable to push blood around the body effectively because the pressure has collapsed the vena cava. Hemothorax and hemopneumothorax. Hemothorax is the chest cavity fills with blood, and then the hemopneumothorax is when the chest cavity fills with blood and air. Most of your trauma patients are going to be typically there in the hemopneumothorax. It just how much blood and how much air, it's almost impossible without a CT. Traumatic asphyxia, sudden compression of the chest, forcing blood out of the organs and rupturing blood vessels. Neck and face are a darker color than the rest of the body. May cause bulging eyes, distended neck veins, or broken blood vessels in the face. Cardiac tamponade, direct pressure to the heart causing blood flow into the pericardial sac around the heart. The pericardium is a lot like leather. It doesn't stretch. And once it feels pressure from the outside, it doesn't beat real well. It beats fine, but the chambers aren't allowed to fill because they're not allowed to relax all the way. Blood back steps into the veins. It's typically the result of penetrating trauma. You'll have distended neck veins, signs of shock, and a narrowed pulse pressure. And what that means is you'll have a blood pressure of, say, 90/80 or 80/70 versus 80/40 or 80/30. Your pulse pressures are typically narrowed. So we covered this a little bit. Blunt trauma or penetrating trauma can obviously cause direct damage to the aorta, where blunt trauma can cause a tear, a severe tear, a sever or a tear of the aorta. Aortic dissection, the inner layer of the aorta begins to tear. Blood flows between layers of the aorta wall. Those are typically very fatal. An aneurysm. An aneurysm is a balloon-like protrusion of the aorta. What that means is not all of the layers of the aorta have ruptured, and the blood is collecting outside the muscle portion of the aorta, but still inside the arterial wall. If that ruptures, it's typically fairly fatal. They're going to complain of chest pain, back pain, abdominal pain, and they're typically going to be fairly unstable. If you have, depending on where the damage in the aorta is, you will have differences in blood pressures between both arms or legs, depending on where that disruption is. Comatochordis is a trauma-induced cardiac rhythm. There's a specific time during your heartbeat that your heart is sensitive to trauma and very vulnerable. If you're struck in the chest at that exact millisecond, they typically go into VFib and go into full cardiac arrest. Pearls of patient assessment for a pneumothorax: respiratory difficulty, uneven chest wall movement, reduction or absence of breath sounds on the injured side. Tension pneumothorax is when the patient becomes, I'd say, more or less unstable, increased respiratory difficulty, signs of hypoxia. They start presenting with shock. They're pale, cool, diaphoretic, distended neck veins, and the last thing that happens is tracheal deviation. Hemothorax. Hemothorax is exactly the same, except they start coughing up like a bubbly blood. It's the easiest way to explain it. And it's inconsistent. Traumatic asphyxia, distended neck veins, head, neck, and shoulders appear of a dark blue color, bloodshot and bulging eyes, swollen and blue tongue and lips, chest deformity or tenderness. Cardiac tamponade is going to present with distended neck veins, very weak pulse, very low blood pressure, and steadily decreasing pulse pressures. Aortic injury or dissection, it's going to be a tearing chest pain radiating to the back. Differences in pulse or pressure between left and right extremities or between arms and legs. A abdominal aortic aneurysm is going to have different pressures and different pulse pressures, so palpable pulses between the arms and the legs. A abdominal aortic aneurysm or dissection will have a palpable pulsating mass in the abdomen and typically leads to cardiac arrest because they run out of blood. Tension pneumothorax or pneumothorax. ALS is where this patient needs to live. Seal all open chest wounds. So we're going to put a chest seal on any openings in the chest. Allow air to be expelled for tension. Manage the patient's airway. We're going to treat with oxygen. Treat the patient's hypoxia with oxygen, and we're going to allow them to stay in the position of comfort. They're probably not going to find anything that's comfortable, but I mean, you can let them try. As always, we're going to maintain an open airway. Anything with chest trauma, be prepared to suction. Administer low supplemental oxygen and transport as soon as possible. Don't delay transport. Don't delay patient transport of 4 minutes by 11 minutes because they need a paramedic. If you're 3 minutes from the hospital, get them to the hospital. Abdominal injuries obviously can be open or closed. Internal bleeding can be severe if one of your solid organs is damaged or ruptured. Evisceration may occur, which means organs are protruding through the wound. That's a good representation of a good evisceration from a stab wound. We'll talk about how we manage that here in just a little bit. Blunt trauma to solid organs can cause life-threatening blood loss. We covered that earlier when I mentioned things like liver lac or spleen lac, which is short for laceration. Injury to the diaphragm can cause detachment, allowing abdominal contents to enter the thoracic cavity. That is called, drawing a blank. I'll come back to it. If hollow organs, they can spill contents into the abdominal cavity, severe irritation, and peritonitis. This is an infection of the peritoneum. Pain, initially mild but rapidly become intolerable cramps, nausea, weakness, thirst, obvious lacerations, and puncture wounds to the abdomen. Lacerations and puncture wounds to the pelvis and middle lower back. Indications of blunt trauma, indications of developing shock, coughing or vomiting of blood, rigid or tender abdomen. That's a big concern because that's just before they run out of circulatory blood. Distended abdomen, and if the patient tries to lie very still, abdominal trauma patients are weird because they'll finally find a position where all of the stuff inside's not jostling around and doesn't hurt. But every bump will kill them. Talked about this at the very beginning of this, the path of the bullet. Patients with gunshot wounds to the lower ribs and same level in the back should be treated for both chest and abdominal wounds simply because you can't prove where that bullet went, and bullets don't take straight paths typically. Both closed and open abdominal injuries. Alert for vomiting for three things. One, to clear their airway. Two, to control their pain. And three, to reduce pressure in the abdomen. Place the patient on their back with legs flexed at knees to reduce tension on the abdominal muscles. Administer supplemental oxygen, treat for shock. No food, no water, and continually monitor vital signs. Open abdominal injuries, control external bleeding, and dress all wounds. Do not touch or replace eviscerated organs. Apply a sterile dressing moistened with sterile saline over the wound. For a large evisceration, maintain warmth by placing layers of bulky dressing over occlusive dressing. Same thing. We don't remove any impaled object. Stabilize with bulky dressing and bandaged in place. Leave the patient's legs found in the position to avoid muscular movement that may move impaled object. That's going to cover what you asked about the T-post or whatever impaled in the patient. That's going to be more crucial than how you cut the T-post or that is, don't allow them to stretch their legs out or put them in the fetal position when you move them. Leaving their legs in the position in which you found them is going to reduce that damage greater than you would cause damage by cutting the post. This is the only time an open wound changes from just open skin. A open chest or abdominal wound is considered to be one that penetrates not only the skin, but also the chest or abdominal walls to expose the internal organs. Open chest and open abdominal wounds are life-threatening. For both open and closed injuries, take appropriate standard precautions. We're wearing our gloves. Note your mechanism of injury, what caused the injury. Protect the patient's airway and breathing. Treat them for shock, oxygen, thermoregulation. And if there are signs of hypoxia or the patient's vital signs suggest the potential for shock, administer oxygen. A flailed chest is characterized by paradoxical motion. If the patient is unable to adequately breathe, assist their ventilations. Seal penetrating chest wounds with occlusive dressing. Monitor the patient for changes and be prepared to manually relieve any pressure in the chest. When they say manually relieve it, when they breathe out, you're just going to lift up on that flap, giving the chest seal just a hair more clearance to clear air out of the chest. Closed chest wounds are sometimes difficult to distinguish or may occur together. Assess the patient, including breath sounds, and maintain ventilation, oxygen, and perfusion. A patient who collapses in cardiac arrest after a force is applied to the center of the chest should receive CPR and defibrillation like any other patient in arrest from cardiac cause. They're talking isolated directly to the center of the chest. That's that commotio-cordis disruption in cardiac function. If the patient develops signs of attention pneumothorax, arrange immediately for ALS intercept or transport promptly to a facility that can treat this injury. We talked about this in length. Solid organs bleed a lot, especially when they're lacerated. When hollow organs are injured, their contents spill into the abdominal cavity, causing irritation and infection or peritonitis. Blunt trauma, penetrating trauma, and compression are mechanisms that injure the chest and abdomen. Open or close pertains to integrity of the chest or abdominal wall, which is the inside lining. Seal open chest wounds to prevent air from entering the chest cavity. Closed chest and abdominal wounds bear a high risk for underlying organ system damage and internal bleeding. Mechanism of injury is going to be your biggest indicator on this as to whether or not you are dealing with a compensated shock patient. Study your signs and symptoms and treatment procedures for specific chest and abdominal injuries. The biggest one is going to be chest seal, whether it's a occlusive chest seal or a flutter valve chest seal, and then practice what you would do with eviscerated organs, because you're like, I know what I'll do, until you're there and you're like, I don't know what dressings to put on this 13 foot of intestines that's now laying on your stomach. It's a lot to figure out in the moment. Questions to consider: is the patient's breathing adequate, inadequate, or absent? Obviously, if it's inadequate or absent, we're going to correct that with assisted ventilations. Are they displaying signs of shock? If they're displaying 2 of the 3 signs of shock, they're compensating. They're short to go into decompensated shock, and they probably need a trauma surgeon sooner rather than later. Is there an open wound in the chest that needs to be sealed? Any open wound to the chest needs to be sealed. Is the patient displaying signs of tension pneumothorax? If they're displaying signs of tension pneumothorax, we need a paramedic or a doctor. Is there an open wound in the abdomen that needs to be dressed or covered? Any open wound to the abdomen at a bare minimum needs to be covered to limit the quantity of infection. You are caring for a patient who was shot in the chest with a nail gun. You applied an occlusive dressing around the wound. The patient is suddenly deteriorating. He is having extreme difficulty breathing and his color has worsened. Breath sounds have become almost totally absent on the side in which the impaled nail. What complication might you suspect be causing this worsening condition, and how could this be corrected? Rapid deterioration, I'm leaning towards probably a tension pneumothorax. And if you applied a 4-sided occlusive dressing to this wound, you're not allowing air to escape. So you do what we call burp the occlusive dressing. You lift up one side of that occlusive dressing while he's breathing and allow air to escape while he exhales. And once that's done, you let it back down. I'm going to have to take about a 2-minute break. Once I get back and get everything set up, we'll finish the 4th chapter and call it a day. Brad, is everybody back?
I'm here.
I'm here.
All right. Musculoskeletal trauma is basically appendage trauma, is the short version. We'll go over the musculoskeletal system in brief. Kind of covered a lot of it with, or you should have covered a lot of it with musculoskeletal or with anatomy and physiology, but brief overview. The bones are the framework. Think of it as like the studs in the wall, the studs in your walls. The joints are your hinges. It's what allows us to move, and the muscles are what actually causes the movement. Cartilage is what allows for flexibility between bones. There's cartilage between your ribs and your sternum. There's cartilage in your pelvis that keeps your pelvis somewhat flexible. There's cartilage in all of your joints. Ligaments connect a bone to a bone, where tendons connect muscle to bone. Um, those are virtually everywhere in the human body. Bones are formed of deep, dense connective tissue. So all of your bones start off really similar to cartilage. That's why when we talk about babies being flexible, more flexible and bouncy, it's because they really are. Newborns' bone structure isn't quite solidified like even a 3 or a 4-year-old is. They're very flexible. That's why when you break, if you were to break a 10-day-old's arm, like it's hard because they're flexible. The downside is bones are very vasculature. They have a lot of arteries and veins going in and out of them, and it's susceptible to bleeding, an injury. Bones actually bleed. Um, it's hard. Well, and once you've done this for a while, you understand that's why we use IOs, because the ostium, the center part of the bone, is where the arteries and veins deposit and remove calcium. And we're injecting stuff through that ostium into the vasculature. So that's how the vasculature is connected to the body and allows us to utilize it for medication administration. The periosteum is the outermost, the densest layer. That's what gives bones their structure. If you ever look at an X-ray, like the inner portion of it's kind of gray and the outer portion of it's white. The periosteum is that white portion that's that dense calcium. Joints are where bones meet. Classification of shape: long, short, flat, irregular. Long are going to be your femurs and your humerus and your ulnar radius, your tibia and fibula. Flat are going to be your shoulder blades, your sternum, and I think irregular is going to be like your pelvis and your shoulder, your acromion process, and vertebrae. And short bones are going to be the ones that are in your hands and feet. Bones heal themselves by ossification, I believe is the word. It's a redistribution of the ostium by collections of calcium. But how that extra calcium gets there to allow for that repair to start all starts with the blood. So the break causes soft tissue swelling and a blood clot to develop in the area. So when you break a bone, it actually creates a sac around that fracture. It's a hematoma around that fracture, and that's what allows the body to push the fibrin and the calcium and all of the things to start that um, reproduction of bone. If it's too much, creating compartment syndrome, it can cause cells to die at the injury site. Cells farther away from the injury start to rapidly divide, forming tissue that heals the fracture that develops into new bone. That's I can't remember the term. Anyways, there's three primary types of muscles: voluntary, involuntary, or myocardial or skeletal. I want to move smooth muscle, which is your blood vessels, your lungs. Um, those are involuntary. The central nervous system takes care of those, and then the cardiac muscle, it does its own thing. Cartilage helps form flexible structures of the body. That's going to be between your ribs, your collarbone, and your joints. Cartilage is in all joints. Tendons allow for the power of movement across joints. Tendons are muscle to bone. Ligaments support joints by attaching bone ends to allow for stable range of motion. So bone, ligament, bone is what a ligament's for. This is a decent representation of the two. This is your knee. Your knee has the most tendons and ligaments in it. You got patellar tendons. You've got ACLs, MCLs, LCLs, and then I don't remember the other two tendons, but it has the largest quantity of ligaments and tendons in the body. Direct force, blunt trauma, falls, car wrecks. Those are going to be your direct force. Twisting or rotational force. That's going to be mostly sports related. Indirect force is going to be typically your blast injuries. Three major types of fractures. Any break in the bone, open or closed. Comminuted is broken in several places. Grain stick is an incomplete break. Angulated is when the bone is broken and it's bent at an angle. That's a closed fracture. That's more of a dislocation fracture. Dislocation is a coming apart of the joint. A sprain is a stretching or tearing of ligaments. A strain is a overstretching or overexertion of muscles. Downside to not having x-ray vision is we can't confirm whether something's broken in the field or not. If it looks like a fracture, treat it as a fracture. A traction splint should be applied to a suspected femur fracture. Only if you suspect mid shaft, don't do femoral head or femoral neck or hip fracture. That can actually cause your patient more discomfort than relief if you try traction splinting a hip fracture. Splinting reduces blood loss from additional trauma. Obviously, we're going to do the same thing we do with musculoskeletal injuries we do with everybody else is we're going to assess their ABCs, identify life threats, treat them as necessary, and then move forward. Obviously, if they have a grotesque injury, they probably have subsequent injuries or as well. We're going to cut or remove the patient's clothing according to the situation. Obviously, if it's an isolated extremity injury, we're not going to cut off all their clothes. If this is a patient who is involved in a MVC with ejection, we're cutting off all their clothes because we need to see every inch of their body. Compartment syndrome is characterized as severe swelling in the extremity as a result of a fracture. Fracture or crush injury causes bleeding and swelling. Pressure builds up in the muscle compartments around the bones. Compartment syndrome is when you lose blood flow in the area. and that creates cellular damage and death. If not treated appropriately with a fasciotomy, you may lose that limb. We're going to assess for pain and tenderness, deformity and angulation, crepitus or the bone on bone feeling, swelling and bruising. We're going to identify exposed bone ends, check bone location or joint location, and we're going to check CMSs. We're going to check for pulses and sensation. So the 6 P's of patient assessment are pain and tenderness, pallor, the color of the temperature, the color of the pale skin, paresthesia, the pins and needles. I'm sure you've fallen asleep with your hand, and when you move your hand, you feel like you're being stabbed in your hand. Pulses, diminished or absent, paralysis, or does it feel like there's pressure? That last one is going to be your compartment syndrome. If they feel like they've got a severe pressure in their hand or their foot or their ankle or whatever's injured, lean towards a compartment syndrome. Oh, goodness. It doesn't take chest, abdomen, or central nervous system trauma to have serious multi-system trauma. 2 long bone fractures, two femoral fractures, 2 humeral fractures. That adds up to serious multiple trauma, especially if they don't have CSMs intact distal the fracture. A pulsus extremity is a trauma alert every day. We're going to take standard precautions, gloves, etc. We're going to perform our primary assessment, ABCs, control massive bleeding, and then during our secondary assessment, apply a C-collar if you think it's, we've already done that because we did that in our primary. Splint any suspected extremity fractures after treating life-threatening conditions. Cover open wounds with sterile dressings. And then we get to splinting. Advantages, it minimizes movement of disrupted joints and broken bone ends. Sometimes it helps with pain, sometimes it doesn't. But the big one is we prevent additional injury to soft tissues, primarily nerves, arteries, and veins. If it's utilized appropriately, it can prevent a closed fracture from becoming an open fracture, and it minimizes blood loss because the more you bounce that closed fracture around, the more it's going to bleed and possibly develop a compartment syndrome. Realignment of the deformed extremity assists in restoring effective circulation to an extremity and simplify splinting. The only time that we're really going to reangulate or realign a deformed extremity is if it's pulseless. If you don't realign it, splinting may be ineffective, causing increased pain and possible further injury. If not realigned, increased chance of nerves, arteries, and veins being compromised. Increased pain is only momentary. Splint in the position found unless distal extremity is cyanotic or lacks a pulse. If extremity is cyanotic or lacks a pulse, align the joint to neutral position using gentle traction. That's something that I can tell you how to do, but we will show you in one of our skills days. This kind of walks you through it. One EMT grasp distal extremity while partner place one hand above and below the injury site. Partner supports first EMT who creates general manual traction in the direction of long axis of extremity. If no resistance is felt, maintain general traction until the extremity is properly aligned and splinted. Effective splinting may require some ingenuity because, well, that's what we do. Three types are typically available: rigid splints, formable splints, and traction splints. Most of your places carry formable splints, SAM splints. Very few places carry rigid splints, and then traction splints are utilized for femur fractures. The vacuum splints, which is what's depicted here on the right-hand side, those are very expensive and commercial. They're very beneficial though. Obviously, before we worry about a broken ankle, we're going to cover our ABCs and our life-threatening bleeds first, and then we're going to expose the injury, and we're going to assess whether or not the patient has circulation, sensory, and motor function of that injured extremity. Align the long bone injuries to an anatomical position as best as possible, and don't push protruding bones back into place. We're gonna splint above and below the injury, and then we're gonna pad the voids. The term splinting to death comes around because there's been several people distracted by a deformed ankle, and they missed the obvious open femur fracture that had an arterial bleed that they didn't address. So splinting the patient to death has happened. Not ensuring the patient has adequate airway, breathing, or circulation. If you put it on too tight, it compresses soft tissues. If you put it on too loose, it allows for too much movement. Splint in the deformed position as best as you can, as long as it has a pulse. Obviously, when you wear gloves, face shield if necessary. If possible, expose the area and manually stabilize it. A lot of times your broken arms or broken legs patients are going to be manually stabilizing themselves. Assess CSM. Realign the injury if deformed or if distal extremity is cyanotic or pulseless. Measure, adjust your splint. I like to utilize the patient's opposite extremity to mold a SAM splint, because obviously it's not injured. You're not going to cause them a whole lot of discomfort sizing it to their opposite extremity. Apply and secure it, and then check your CSM again. That's how you're going to know whether if your splinting is too tight. Traction splint counteracts muscle spasms and greatly reduces pain. There's two different types. There's bipolar and unipolar. The amount of traction should be roughly 10% of the patient's body weight, not exceeding 15 pounds. Don't know if our traction splint has a pound or a weight on it. I don't believe it does. I don't think it's capable of producing more than 15 pounds of traction, though. Standard precautions, obviously gloves, and if possible, expose the area to be splinted, manually stabilize the leg, and apply manual traction. Assess CSM distal to the injury, adjust the splint to the proper length, and position it at or under the injured leg. Apply the proximal securing device, the one closest to the hip. Apply the distal securing device, the ankle. Apply manual traction, and position and secure the remainder of the straps. Reevaluate the CSM. Check all of the securing devices, make sure they're still tight, and then secure the patient's torso and traction splint to a long spine board to immobilize the hip to prevent movement of the splint. Shoulder girdle injuries. Pain in the shoulder, drop shoulder, a severe blow to the back over the scapula is what's going to cause these injuries. Assess distal CSM. Use a sling and swath. If evidence of an anterior dislocation of the head of the humerus, place a pillow between the patient's arm and chest. Don't attempt to straighten or reduce. That can cause severe vascular injury. Pain in the pelvis, hips, groin, or back. Pain when pressure is applied to the iliac crest. Cannot lift while lying supine. Lift legs while lying supine. Lateral rotation of the foot. Unexplained pressure in the bladder. Bleeding from the urethra, rectum, or vaginal opening. That's going to be your open book pelvic fractures. Move the patient as little as humanly possible. Make sure that they have pulses, sensation, and motion in their feet. Straighten lower limbs to anatomical position, stabilize lower limbs, and assume if their pelvis is broken, so is their spine. Once you realign it, reassess for CSM, treat for shock, and transport the patient as fast as possible. Pelvic, that's what I was going to say. I don't know if this was on here. Pelvic binders, commercially available devices. However, you can utilize a bed sheet. And we will go over that on a skills day. This needs to be applied to all patients who have a pelvic deformity or instability, whether or not shock signs are present. Believe that's I think that's the SAM traction or the SAM pelvic binder. No, that's not the SAM. I don't remember which one that is. This is the method of applying or utilizing a sheet as a pelvic binder. With the exception of it's hard to tell, but the top of the sheet needs to be right at the top of the iliac crest. Hip dislocation. Anterior hip dislocation is easy to see. You can see that the hip bone is above the pelvis. Posterior hip dislocation, on the other hand, is a little harder to distinguish between a posterior hip dislocation and a broken hip. Rotation of the leg inward and the knee is bent. The foot may hang loose and unable to flex the foot or lift toes, and lack of sensation in the foot or leg. Patient care, you're going to assess CSM, move the patient onto a long spine board, immobilized limb with pillows and blankets, secure patient to the spine board, care for shock or reassess for CSM, care for shock, transport, monitor vital signs, and check for nerve and circulation impairment. Geriatric note, we all know that anybody over the age of 55 is more susceptible to hip fractures because of brittle bones or weaknesses from various diseases. So hip fracture. The difference between hip fracture and pelvic pain is the pain is localized. It's going to be localized to the head of the femur or the lateral aspect of the hip. Sensitive to pressure exerted on the greater trochanter, which is if you put your hand on your hip, it's the pointy bone that's inside your hip. That's the greater trochanter. You'll have some swelling or discoloration around the hip area. They're unable to move their hip while they're laying on their back. They can't stand up. And the foot on the injured leg turns outward. And sometimes, not always, that limb will appear shorter than the uninjured leg. We're gonna buddy splint the good leg to the bad leg with a blanket between the two legs, and then use thin splints to put and then splint or pad the voids and readjust. Femoral shaft fracture. This is typically presents with intense pain, sometimes open, sometimes shortened. Um, Care for this is going to be control bleeding if it's open, treat for shock. Um, Assess whether or not they have a pulse, sensation, and motor function in that leg. Apply the traction splint, and then reassess CSM. Pediatric note, obviously, we don't want to try to use an adult traction splint on a kid. It's not going to fit right. Knee injuries, pain and tenderness, swelling, possible deformity. Um, the knees are simple. We're gonna assess whether or not they have CSM. You're gonna mobilize it where you find it, and then reassess CSM. Tibia or fibular injury, those are going to be typically distal in nature, right around the ankle. Pain, tenderness, and swelling are real common. Probable deformity. Apply a vacuum splint if you had one, an air inflated splint, or utilize a SAM splint or a moldable splint to stabilize the ankle. Or sorry, tibular, fibular. Same goes for the ankle. Forearm, wrist, and hands injuries. Most of the time, those are going to be deformed, going to be painful. We're going to splint them. Forearm and wrist, we're going to splint them how we find them as long as the CSM is intact, and we're going to check it before and after splint application. Splinting a finger, we're going to use the buddy tape system because we don't carry finger splints. That's pretty much standard of care across the board. Finger splinting is we're going to buddy tape them. Things to remember about broken bones as they bleed. Not a lot of people realize that bones have vasculature in them, and fractures cause more blood loss than the tearing of the muscles around them until you hit a vessel or an artery. Serious or multiple fractures can cause shock. Femur fractures or bilateral femur fractures can cause a patient to bleed out. Splinting of long bone fractures involves immobilizing both ends as well as adjacent joints. So if you're splinting the left femur, you need to also make sure that we're securing the right leg. Splinting protects the patient from further injury. It says it reduces pain. I just say it doesn't exacerbate the pain and helps control bleeding. Sometimes you need to get creative with bleeding because not every patient's built the same. But as long as you pad the voids and you put the patient in the position of comfort, I call it a win. And injuries to bones and joints should be splinted prior to moving your patient. That kind of goes the wayside a lot of times because people want to do everything in the bus. But we need to treat then transport. We need to be doing what's right for our patient and minimizing damage. If a patient has multiple trauma and appears to be in shock, don't waste time splinting individual fractures. Place them on a spine board, secure the limbs to the spine board, and then you can splint the individual fractures on en route to the hospital if you have the ability to. The backboard is one human-sized splint. So worst case scenario, they're on it for 15 minutes on the way to the hospital, and once they get there, they get the pan scan, they can take them off of it. Bones, joints, muscles, cartilage, tendons, and ligaments make up the musculoskeletal system. Bones are what provide our structure. They store calcium, they produce red blood cells. And then we all know what joints allow us for. Fractures, dislocations, sprains, and strains are musculoskeletal injuries that are caused by direct force, indirect force, and twisting force. And injuries should always be splinted prior to moving your patient. A closed extremity injury is one in which the skin has not been broken. An open extremity injury is one in which the skin has been broken. Pelvic fractures and femoral shaft fractures often indicate more severe internal injuries. It's going to be good for you to practice all of your splinting and immobilizing techniques, but also learn what you have around you, because there's only general rules of applying splinting. It doesn't say you have to utilize the same thing every time. As long as you put the splinted extremity or injured extremity in the inline neutral position and it's comfortable for the patient, it's appropriate. Questions to consider. Did you fully address your patient's life threat and maintained all of your assessment priorities in the presence of a grossly deformed extremity? Or do you have a patient that requires splinting? If they have multiple fractures, are they multi-system trauma or are they in shock? Do they have adequate CSM distal to the musculoskeletal injury? If they don't, should you align the angulated extremity injury? Patients who suffer fractures can be in extreme pain. Pain can cause anxiety and elevated pulse rates. How could you differentiate between a patient with a rapid pulse and anxiety from pain versus a patient with a rapid pulse and from anxiety and shock? Mine is you're going to look at your patient's skin tone and their mentation. Pale, cool, diaphoretic, probably shock. Skin's pink, warm, and dry, and their heart rate's 112, probably anxiety. Skin doesn't lie. That's the one thing on your patient assessment that will never lie. I've heard it a couple of times in my career, and it still stands true to this day. Anything that makes you pale, cool, and diaphoretic will kill you. Any questions for tonight? Well, if there's no questions for the night, I will let you guys go and do some studying, and I will let Jake know that he can close out the Zoom meeting.
Sure.
Love you. Bye.
Bye-bye.
Thank you.
Thank you, Wayne.
Yep.
Thank you.
Tell Wayne that Connor says.
Connor says hi, Wayne.
Hi, Connor.
Ah! Woo!